Okay, good morning, everyone. Let's get started. I think for those in the room, we have a new mic system. Hopefully you've all been shown how that works, so we'll know how to come in. Those online, hopefully that won't affect you and you'll be able to hear us all okay. We have apologies from Victoria McCrae, who's going to be a little late, and from Sharon, but Amanda is here in her place as carers rep. Are there any other apologies? Okay, just does someone have sound on in their laptop? Me. Hmm? Hmm. Okay, we're continuing to have a look to see if we can sort out the sound quality. Okay, I'm going to move on for now. Hopefully we'll get the sound sorted as we move through. Thanks, Roger. Are there any declarations of interest in relation to any items on today's agenda? No, not seeing anything. Can we move then to the minute of the last meeting, which was held on 31st October? Any items for accuracy anyone wants to raise on page 4 of the pack? 5, 6, 7, 8, 9, and 10. Okay, are we happy with that as an accurate record of our last meeting? Thank you. Item 4 then is the action log. So there are only 3 actions on there, one of which has a timeline of March, so we'll come back in due course. And the other 2 are on today's agenda, so will be dealt with. And that seems fairly straightforward. Any questions on that? Move on then to item 5, Chief Officer's Report. Gail.
Thank you very much. So I'm happy to present the Chief Officer's Report this time. It's a fairly comprehensive report. It consists of a number of local, regional, national updates and a number of recommendations, which I'll come back to. So first of all, I'm just going to highlight some things within the report. So just to highlight, there was an event around keeping the promise in partnership earlier on, which included the promise delivery partner from the National Promise team who came up and met with colleagues here in Falkirk. We've been doing some work around our governance of the IJB and PAC membership. So our business and governance lead will be reviewing the IJB standing orders and bringing forward proposals for updating them in January 2026. And when I come on to the recommendations, you'll note there's a number of recommendations relating to membership, including extending the appointment of some of the non-voting members for a further 3-year period. I would highlight that work is ongoing around the recruitment of the third sector representative. It's not yet concluded, so we hope to be able to bring a recommendation around that in January. We've currently got a vacancy on the Performance Audit and Assurance Committee for a voting member, and the IJB will be asked to approve the appointment of Alison Japp to this position in line with standing orders. Also to highlight, we had the Care Experience Week recently, so we had a number of care experienced young people and adults from across the area helping Falkirk mark the Care Experience Week for the first time in 6 years. We've recently, this week, had the publication of the Strategic Integrated Inspection of Care at Home Services. So that was published on Wednesday this week. There will be a briefing coming out to members, and we'll bring forward a report on that to the next IJB. It was largely a positive inspection, with some areas for improvement which we were aware of in advance of the inspection, and work continues on those, and we'll bring further information on that through to the PAC committee and a future IJB. Gender-based violence and the 16 days of activism. This is currently ongoing at the moment. The campaign runs between the 25th of November and the 10th of December, and there's a wide range of events and activities to mark the 16 days of activism. There is information on this available, and encourage colleagues and partners to come along to these events. Over the last few weeks and couple of months, there's been a number of awards and achievements. Our teams have been successful. They want to recognise the excellent work that has been recognised nationally. So at the 2025 Scotland Health Awards, the Children's Speech and Language Therapy team picked up 2 national awards, the Innovation Award and the Tackling Health Inequalities Award. Charmaine Black, one of the Community Learning Disability nurses, won the prestigious Nurse Award. And our prison healthcare team at HMP Stirling won the Unsung Heroes Award. Falkirk Council's Mobile Emergency Care Service, the MEC service, has been awarded the Scottish winner in the Home Care Team category in the 2025 Great British Care Awards, and they now go on to the UK awards, which will be considered next year. And Falkirk Council, in association with the Health and Social Care Partnership in relation to the work around Japp Gardens, won the Excellence in Accessibility and Inclusion category in the Chartered Institute of Housing Scottish Housing Awards 2025. So it's really good to see all of the hard work undertaken by a range of teams across the partnership being recognised in this way. In terms of regional updates, there's an appendix to the paper entitled Transformation Through Collaboration. And this was presented to a meeting of Falkirk Council and Clackmannanshire Council on the 27th of November. And it notes the potential for further transformational change through collaboration. Colleagues will see in the report that a number of the services identified in Tranche 1, which may be suitable for wider partnership working across one or more council areas, are services which are delegated to the IJB. Officers will continue to explore the opportunities and report back to IJB in due course with any proposals for change. The report recognises that the HMIPS inspected HMP Glenoakle recently against 9 standards, including Standard 9 Health and Wellbeing, which is led by Healthcare Improvement Scotland. The prison achieved an overall rating of good, which makes a significant improvement for the previous satisfactory rating in 2022. And this is the first prison healthcare team in Scotland which has received a good rating since inspections begun. Again, a full report and associated improvement plan is being considered through our Clinical and Care Governance Management Group and will come through to the next Performance Audit and Assurance Committee. In terms of national updates, there was a recent call for proposals to submit proposals for GP walk-in services. So across Forth Valley, we have submitted a proposal. We understand that will be considered next week and will provide an update at the next meeting. And I also wanted to mention that Scottish Government has announced significant uplift for general practice funding. So over the course of the next 3 years, there'll be new additional recurring funding moving to a recurring 249 million across Scotland over the next, in 3 years' time. And I think this will be a really significant impact to the capacity within our GP services. And we'll bring more information on that to IJB as details emerge. So if I go back to the recommendations. So the IJB is asked to note the reappointment of Andrew Murray, Medical Director, Karen Gowdy, Executive Nurse Director, and David Heron, the GP Clinical Lead, as the non-voting members of the IJB for the 3-year period through to December 2028. The IJB is asked to note the update regarding the third sector representative, and I just would like to change that to note that we'll bring forward a proposal to the January IJB around a proposal for the new third sector representative. The IJB is asked to approve the appointment of Alison Japp to the Performance Audit and Assurance Committee as a voting member. And finally, the IJB is asked to note the report being presented to Falkirk, that was presented to Falkirk Council on the 27th of November, entitled Transformation Through Collaboration, and endorse the intention to explore opportunities through collaboration to support sustainability, and agree that the IJB will receive further progress updates and specific reports on the subject in due course. Thank you, and happy to take any questions.
Okay, thanks, Gail. An awful lot in there and some good news as well. Great to see people recognised for the work that they're doing. So congratulations to all of those who've won those awards. Are there any questions or comments members would like to make? Fiona.
Thank you. A really great report, and I echo that. Maybe I'm echoing, I'm not sure. But really great, the awards and the recognition of staff. I was going to ask about timescale for the walk-in pilots, but you actually answered that. But I wondered if you might be able to say a little bit more about the market facilitation plan and what that means for the development of services in Falkirk.
Okay, I think Marie's going to answer that one.
Yeah, thanks. So Suzanne Thompson, our commissioning lead, is now in post and has brought together the commissioning team. So we do have a market facilitation plan, which was way back from 2017. So we thought it was really good timing to update the plan in line with the development of the strategic plan. So now that we've brought the team together, we're looking at how we might best commission services for the Falkirk area. We're looking at pulling together as much information around contracted services that we have, developing that relationship with our providers, making sure that we are absolutely aware of all of the market conditions as we take forward, the challenging financial circumstances that we have. So it'll be really important that our financial plan links to the market facilitation plan and links to the strategic plan moving forward. So it's the early stages, but we are developing that alongside Tom and his team around the strategic plan as well.
Thanks. I've got one more question just around, I think it's great around the uplift of GP funding. And I think, as individuals and certainly any of us who are involved in the board or the as councillors know that this is a really significant issue. Given the, I suppose, overcommitments around the primary care improvement plan, will some of this funding be aligned to supporting that?
That's a very interesting question, to which I do not have an immediate answer to. The detail of what's presumed to be for that money's to be used for isn't available to us yet. PCEP is always seen as something entirely separate, and so it is unlikely that it will explicitly allow that to happen. However, in terms of ensuring greater access and capacity, etc., for individuals coming forward to see their GP or associated professionals, it may well be that it will actually assist in reality the patient experience. But as yet, we don't have any details on whether or not the money can be moved around to support certain areas of activity.
Hey, thanks for that, Tom. I'm going to bring in Roger and then David.
Thanks, Chair. I've just got a query around the plans to look at joint services with Clackmannanshire and elsewhere, possibly. And of course, nobody can object to collaborating with other areas around us, and there's been very successful collaborations for many, many years. You just have to look very close here to JLAS and the Sensory Centre, and there's many, many more where it makes absolute sense. However, I remember very well the attempts to merge services between Stirling and Clacks a number of years ago, services of social care services which fell apart in a very expensive way and caused lots of additional costs when they had to be pulled apart. So I guess I'm just saying, can we be pretty cautious at times and look at it fairly carefully before jumping into too deep water? Thanks.
Yeah, thanks, Roger. And just to confirm, as you say, there are some, we already work collaboratively around a number of services. JLES is one example, but also if you think about the health services, so Falkirk hosts prison healthcare, Falkirk hosts primary care. So we've actually got quite a lot of experience of that working relatively well. I think we're still doing some refinement around our overall governance, so the learning that we have will help inform what's taken forward. But I just wanted to provide that assurance that obviously conversations will be happening at officer level. If there are any proposals, they will come through. If it's a delegated service, it will come through to IJB to take a decision on that. So you'll obviously have that opportunity to scrutinise and make sure it provides the assurance that you'll be looking for before agreeing to any proposal.
Thanks, Gail. I mean, particularly, I suppose, many services which the evidence would say is best come from the coalface, best come from a very locality level rather than from above. Social work services, which everybody knows I'm involved with, being one where the evidence is very clear. We should be looking from community base upwards rather than imposing from top down. Thanks, Gail.
Okay, thank you. David and then Councillor Hannah.
Thank you, Chair. I really just wanted to say I thoroughly enjoyed reading the report from Gail. It's quite comprehensive and excited to see that staff are being openly rewarded and recognised for that. That's a good thing. I suppose I really wanted to say it was good to see the Scottish Government has allocated more money for primary care services on the 240 odd million. What proportion is likely to come to our area?
It's difficult to be precise, but assuming it's an NRAC formula and assuming everything else is equal, it would be in the region of £6 million that would be coming into Forth Valley. So that's not Falkirk specifically. And then, of course, there would be elements of how that is then distributed. So it's a substantial amount of money. Yeah.
Thank you very much.
Okay, Gail, do you want to add to that?
So the NRAC formula that Tom's mentioned is the sort of usual formula, but we don't actually have confirmation yet around which formula will be used. So that might be one way of doing it, but there might be a different way. So until we get confirmation from Scottish Government, we can't confirm what the amount would be.
Okay, thanks. Councillor Hannah.
Thank you, Convener. Just like to echo Councillor Colley's congratulations to the staff who have all gone above and beyond and got some excellent awards. Obviously, it's a testament to what's the good work that's being done by staff. And it links in a little bit with the issue about the collaboration report. I think it's important to be clear that collaboration report is actually just about doing some more scoping work. It's not actually about implementing anything at this stage. We did have extensive discussion at the council on it, and I think everybody is in agreement that we need to look at shared services where that's in the interests of good services. But we also have to do it cautiously. So I think that's important. And in relation to the issue that Roger raised, it was raised at the council as well, the importance of not just consulting, but actually engaging frontline staff, because they are the ones who know what works and what doesn't work on the ground. So I think it's just an assurance that those things are all being considered in it.
Okay, thank you. Stephen, did you want to come in?
No, Chair, thanks. It's actually Councillor Hannah's point just about, where we were in that journey. So, and I was just going to ask a little bit about how's that journey reflected on our risk register? But I'm probably getting ahead of my time there because we're just agreeing to do some more scoping in this. But thank you.
Okay, thanks, Stephen. Okay, if there are no further questions, can we look to the recommendations then? So we are asked to approve Alison Japp as a member of the Performance Audit and Assurance Committee, and then note the various reappointments, the fact that we will have more detail on the third sector representative at the next meeting, and note the report on transformation through collaboration. Is that agreed? Okay, thank you, everyone. Can we move on then to item 6, which is the business case and medium-term financial plan update? Marie.
Thanks very much, Chair. So this is the updated business case and 5-year financial plan, setting out the known pressures at this stage, funding assumptions and next steps towards setting the IJB's budget for next year and the planning for the medium term. The October IJB heard that at that point a projected 5-year gap of 19.1 million had been identified. And since last reporting, some changes have been actioned within the overall position and now show in the position shown in Appendix 1 as follows. So additional non-pay uplift funds for 26-27 have been included based on financial planning assumptions notified by NHS Forth Valley, reducing the gap by £567,000 for next year. I have also had a recent indication, which isn't reflected in the paper at this point, that it would be reasonable to assume that this is a recurring item in future years, which will further improve the position at the next update to the IJB due in January. Pay uplift for an NHS agenda for change has now been agreed at 3.75%, which increases the pay burden, but this is assumed to be fully funded, therefore no overall effect on the position. Scottish living wage estimates have been updated in relation to the indicative hourly rate of £13.45 for next year. This is also accompanied by an assumed increase in funding from Scottish Government at this stage, although the overall liability is still greater than indicative funding. The current projected overspend of 4.887 on set-aside budgets in relation to large hospital services is now included in Appendix 1 as a pressure, along with the assumption that this will be funded by NHS Forth Valley, as is normal. Income budgets are currently projecting an overachievement at this time in social care, therefore an indicative budget adjustment of 70,000 is shown at 4.19, also contributing to reducing the overall gap. Efficiencies for prescribing improvement initiatives of 4.2 million have now been incorporated into projections over the 5 years, with updated estimates being finalised by prescribing colleagues for consideration by the IJB to be brought forward along with the budget in March. Further inflationary pressures for council budgets of 50,000 have also been added in line with latest estimates provided by the council finance team. Also shown in Appendix 1, the position at that time in relation to children and families' medium-term financial plan is noted, although not incorporated into the overall position at this stage, pending further discussion with Chief Exec and Chief Finance Officer of the Council. The table at 4.19 in the report shows the updated gap incorporating these adjustments, and the gap is at this stage is 14.3 million over the 5 years, with 1.8 of this total related to next financial year. This is an improved position since last reporting for the 5 years of 4.8 million, although a number of key risks remain. Since the time of writing the report, the updated medium-term financial plan for children and families has been presented to the Closer to Home Board, which now indicates a balanced budget over the 5-year period, and this will also be updated for the next report in January. Excuse me. There has been a significant amount of effort in achieving this estimated position for children and families' budgets, and progress on the measures to achieve the balance will be monitored through our Strategic Planning and Transformation Board moving forward. The budgets for prison healthcare are not included in the paper at this stage. Work is ongoing in relation to the business case to be presented to Scottish Government, which has incorporated recommendations for staffing arrangements following the most recent fatal accident inquiries and taking account of increasing prison numbers. Work is underway to identify solutions to the remaining budget gap, including examination of already agreed proposals to refine and update the indicative savings already agreed this March in 2025, where possible. The management team are also identifying additional efficiency and transformation proposals to be brought to our next IJB development session to be held towards the end of this month, to be followed by a period of consultation as appropriate, which is now likely to begin in January. Risks are set out in section 5, with the main areas in relation to ongoing demand for care and support at home, long-term care placements, national care home contract negotiations, which become increasingly difficult year on year, provider pressures and pay awards. The primary care improvement programme, as has already been mentioned this morning, is currently overcommitted and being addressed via one-off reserves at this time. This is not a sustainable position, and work is underway to bring forward options to address this overcommitment moving forward. No pressures are included in this regard for PSIP at this stage. A business case in relation to the Shift in the Balance of Care project is currently being prepared to request that funding is made recurring to ensure continuation of the discharge to assess approach, which has been undertaken this financial year. Agenda for Change reduced hours also poses a risk to the overall position, with work underway to understand the overall impact versus funding available. Outstanding job evaluations for a number of council posts have not been included in current assumptions, and updates will be provided as the evaluations progress. Finally, Scottish Government have indicated that the redistribution of Scottish Government funding in relation to social care indicators within the overall local government finance settlement may have an impact on council funding allocations. The outcome of this exercise is not yet known, but may have an impact on funding available to the IJB from Falkirk Council. In summary, the budget gap has reduced from 19.1 million to 14.3 million since last reported to the IJB, based on updated information available at the time of writing the report. Work is ongoing to identify further solutions, and discussions will continue with Chief Executives and Chief Finance Officer of our partners to ensure transparency of the position as the process progresses. Additional information is emerging, which has improved the position further, notwithstanding the risks set out in the paper. The recommendation is for the IJB to note the funding pressures set out in the paper and risks identified at section 5, and the actions required and carried out to date to bring forward the 26/7 business case and medium-term financial plan. Thank you. I'm happy to take any questions.
Thanks, Marie. It's clear as always. Kind of shows where we are, that 14 million of a gap is a good news story. But there will still be some difficult decisions to close that gap as we move forward. I'll take Councillor Hannah and then Alison.
Thank you, Convener. I want to say thank you to Marie, as ever, for her very clear explanation of some very difficult stories. Obviously, we're concerned about the level of funding. Just, first of all, I wonder if you could just clarify set aside. The set aside issue is, I know we've had it explained a number of times before, but I think there are new people on the board that it might be useful for, and even some of us who've been here for a while like to be reminded.
So the set aside budget is in relation to unscheduled care items for large hospital services. So although it's delegated to the IJB and has been since the outset, it's been difficult to understand the activity behind that for the IJBs to influence that spend. So no IJBs cracked it to my knowledge at this stage. So at the moment, what happens and what has happened since the inception of IJBs is that budget is covered by NHS partners at the end of the year. So any projected overspend is noted within the IJB position as it's delegated to us. However, because of that we're not able to exert influence around that activity to the extent we might want to. NHS Forth Valley cover that overspend position at the year end, and that's happened historically and to date. We do have an outstanding audit action around that to understand the activity better underneath the set aside arrangements, and that's in the diary for next financial year. But we should be taking forward some activity data around that, and we'll report that back. But as I say, it has been a difficult thing for IJBs to move forward with.
Thank you. Another question I have is, I'm aware that there's been discussion between COSLA and the Scottish Government about the overall funding position, but I'm not aware of the detail because that's as yet not been shared with us. I wonder if you're able to give us any further information about the discussions that are going on and how that might impact.
Yeah, thanks. So we do know that COSLA have written to Scottish Government around the funding implications, and there has been a meeting held with COSLA and Scottish Government. I don't know the outcome at this point of that meeting. We do get updates through Chief Finance Officer networks, and our next meeting is actually it's during my next annual leave, but I'll get an update following that network meeting next time. But the latest information we are receiving is that there is no additional funding. We need to move forward with our plans around closing budget gaps at this point, and that's the information we're receiving from Scottish Government at the moment.
Thank you. Look forward to the new information in January then.
Okay, thank you. Alison and then Roger.
Thank you. So first of all, just to say, really positive to see the improvement from the last period. Every improvement is incredibly helpful and positive. So that would be my starting point. But I continue to worry about the additional pressures and risks because they could be problematic as we kind of move forward. And some of those look like they could be a range of size and scale, but at the moment are unquantified. And that's really where my first point comes from, and it would be really helpful if we could try and quantify those so that we've got a scale of the level of risk that's sitting there. I appreciate how difficult that is, but it would be good to have a view of that. And the second point is tied to that, and it's really that most of those aren't single year pressures and risks, they are multi-year pressures and risks. So therefore, if they are going to impact us this year, it is likely that they will change the multi-year outturn as well. And it would be good again to see what that does to those outer years as well as this year.
Yeah, absolutely. I totally understand your concerns there. So what I was planning to do for the January paper is bring forward some sensitivity analysis around that as well. So that's not incorporated as yet. Normally that comes with the budget paper, but for me it would be good to have that early look at what that might,
that would be fantastic.
What the implications might be. So I'm planning to bring that forward along with the January paper just to give an indication of what that might look like.
And I think my ask would be, given the ongoing movement in budgets, they are not stable, and the environment in which we're operating is not stable as well. It might be worth doing it more than once a year, just at the budget point, because that sensitivity analysis will change. But yeah, that would be fantastic, Marie. Thank you.
Absolutely.
Okay, thank you. Roger and then Councillor Connolly.
Thanks. Marie, there's an IGP development day just 2 days before Christmas when I gather you're going to present suggestions for savings and cuts. Is that a good time to have, I know it was originally scheduled for earlier, is that a really good time to have that IGP development day?
So I think it's really important. We're actually having an extended senior management team meeting this afternoon where we're going to be looking at proposals that are coming forward. So this is our first chance as a management team to examine those proposals, have a think about the whole system implications, any unintended consequences. I just think it's really important to give members as early as possible indication of what's coming forward. If there are issues around attending because it's just before Christmas, then we can look at maybe doing a couple of sessions, doing more than one session around that. But I just think it's really important that as they're brought forward, we have them on the table and for IGB members examination as early as possible. I have some annual leave as well. The week after next.
Leave as well, so I won't be there, and I'm sure many people will be looking forward to Christmas rather than thinking about cuts just before Christmas. Thanks.
Okay, thank you. Councillor Colley and then Amanda.
Just check my red lights on. I suppose it probably builds on the point Alison made around the risk, particularly around pay and staffing. I suppose the issue around the potential recurring pass-through around council funding, and I know that has been an issue before. And I guess likelihood of risk likelihood of that happening, I think is one. And similarly with the agenda for change, that there's not the early indication that the funding's not going to be sufficient, and trying to get an idea of what that looks like. I had a specific question around the job evaluations, and I know obviously I don't want to ask what roles are in or anything like that, but do we have a kind of quantum of how many roles we might be talking about who've come forward in relation to additional roles being submitted? So how many staff, I guess, and what does that look like in terms of what we might be experiencing? And I would say, I would like to make the point that I think in terms of the job evaluation we had in relation to home care, and I think there's always, I think in general, I always think it's positive when people are rewarded effectively for the roles that they do, but I do want to make that point, but I do think it's a risk that's sitting there, and to get an idea of what that looks like.
Yeah, thanks for those questions. Yeah, around pay. So at the moment, we have been passed over the additional funding from the council for this financial year's additional 1% for council. The assumption in the planning at the moment is that we will get that on a recurring basis, and we will also get the 0.5%, which is over the 3% indicative amount for 26/7 as well. The finance settlement is always a risk for us, that redistribution work that's ongoing, and also the fact that the settlement announcement is 13th of January this year, which is later than normal. That will cause particular difficulties for councils across the country for their financial planning, and also for the implications for the IJB as well. I'm working closely with Amanda to make sure that the assumptions that I'm making are in line with what she is as well, and we're having regular conversations around that. And as soon as we understand the implications of the redistribution, we'll be working that through in our financial plans and having those regular discussions. The likelihood, we just don't know that at the moment. Unfortunately, until we see the settlement. I mean, it's sounding a bit more positive. However, I wouldn't like to hang my hat on that right now until we see the settlement information. So again, I'm making those assumptions. I'm making sure they're in line with what Amanda's assuming for council budgets as well. Around the agenda for change, reduction in hours, that work is actually ongoing right now. So schedules are being pulled together right now around what are the FTE implications, and are they realistic, and what is the real implication of that to return. So that's being gathered by NHS finance colleagues, and we're contributing to that process at the moment. And again, as soon as that emerges, as soon as we understand what that position looks like, I would be reporting that in the next budget update if it's available. For the job evaluations, there are a number of roles. I'm not sure of the number of posts right now. I've got information, but I can certainly get that to you. I don't have it in front of me right now, but I can certainly get that to you. With the early discussions I've had around this with finance colleagues, that they've changed the way that they're budgeting employee costs at the moment, in that they're keeping vacant posts budgets in a separate line now. So they are indicating to me that they think we may be able to deal with that around those vacant posts budgets. However, I don't know the final answer to that. That's just an early indication. However, there is also the implications of the backdating of that. So for the carers roles, the backdating was picked up by the council. We will have to keep having those discussions with the Chief Executive and the Chief Finance Officer around that position as those job evaluations progress. So I'm sorry, I feel like I keep saying I don't know the answer yet, but obviously we don't know the answer. But some of that sensitivity analysis will bring forward, we can include what the indicative amounts are for those as well. So that will depend on what our reserves balances are at the year end, what funding is coming over through that distribution method change, Scottish Living Wage uplifts, and what the liabilities are around that as well. So there's my favourite saying is that there's a number of moving parts in that, and we'll keep those conversations open, and I'll be updating the IJB as soon as we know the information around any of those things.
Okay, thanks, Marie. Amanda.
Thank you. It's just, I've got a question, carers, from the shift in balance of care. I think carers are quite anxious about, there's going to be a lot more care packages in place, and if there's more care companies coming in? Is there going to be an overall kind of universal kind of training that they're all given the same standard of care? Because I think that carers are quite worried about that it's not going to be consistent and it's going to be a lot of different kind of care companies involved in this. Thanks.
Thanks for that question, Mandy. So we actually have a care and support at home framework in place, and the providers who come onto that framework are vetted in the normal way through a procurement process. There won't be additional care companies coming onto that framework during the period of the framework, so it's all the same companies we'll be working with, certainly around option 3 care packages. We've convened a user intelligence group around the next stage and when that contract runs out. So we are looking forward to that, moving forward with that as well. But at the moment, for option 3 packages, there wouldn't be any additional care companies coming in, and they're all bound by the rules and regulations we have around training and monitoring information. They're monitored regularly as well through that framework. I hope that helps to assure you.
Yeah. Can I also ask about, there's also a lot about hospital discharge and our carers being involved in that discharge for someone to come home, because that seems to be a bit of a gap in getting these kind of packages put in, and it's all falling on kind of carers.
So, Carolyn, do you want to take that one?
Thank you. So in terms of, so if I can just go back to shifting the balance of care as well, because that's all linked in terms of hospital discharge and planning. And we work quite closely with the carer support workers, so like Katie, that is employed by the carer centre, to make sure that we're considering that carer stress and distress and the pressure that's on carers. And it's one of the criteria that we look at in terms of shifting the balance of care. We're also looking at how do we strengthen our approach to hospital discharge across. So people that perhaps need a lower level of care to return back home, or perhaps require equipment or the MEC service, and making sure that we're taking into consideration what the carer's needs are alongside the individual that's been discharged. We recognise it's a work in progress, and one of the things that we're looking at is having an integrated discharge service and making sure that the carer support worker is integral as that, so that we can ensure that we've got that holistic approach around it. So I'm quite keen to look at how we can strengthen that, and I'd be really interested to have a conversation to look at, as we develop it, we're going to have like a short life working group that's going to drive that work forward. And I think it's key, so we've got the carer support worker, but perhaps we need to look at perhaps a carer's rep being part of that group. If you feel that would be quite helpful.
That would be helpful, yes.
Okay, sounds good, thank you. If there are no other questions around the room, then can we note the funding pressures and the various risks identified and the actions required that will be carried out? And this is an ongoing process, as we've said. There are a lot of assumptions that are best assumptions at the moment, but some of them will change over time. So can we note the report from now? Okay, thank you. Can we move on then to the next item, which is the budget monitoring report? You again, Marie.
Thank you, Chair. This report sets out the position based on projections prepared for month 7 to the end of October. The overall forecast for integrated services is an overspend of £6.5 million at present. Social care is projected to be overspent by £7.8 million, and health shows a projected underspend of £1.3 million. Set-aside budgets, which we've mentioned earlier and talked through for large hospital services, is currently projected to overspend by £4.9 million, and it is assumed that this will be funded by NHS Forth Valley, as in previous years. The budget set for this financial year included assumed contributions from partners totalling £3.962 million, which it is anticipated will be required in full at this stage, along with full use of our contingency reserves held. The reserves position is shown in detail in Appendix 5. Earmarked reserves of £13.3 million and contingency reserves of £2.4 were held at the start of the financial year. There are currently commitments of £12.8 million against earmarked reserves, with an expected remaining service pressures reserve of £670,000 at this stage. Based on current projections, it is anticipated that we will require to draw our contingency reserve in full. The main areas of variance within social care budgets are as follows. Care and support at home are expected to overspend by 2.9 million. Within that, our external services are projecting an overspend of 6.9 million, with the projection rising since last reported due to increasing hours. A 5% increased hours assumption is included in that projection in relation to anticipated winter months pressures. This overspend is offset by an underspend of 4.1 million on the in-house service. As I normally report, this is due to a number of vacancies pending the care at home redesign work. In-house residential care is projected to overspend by £1 million, despite additional funds being added this financial year. Control of agency spend is continuing where possible, and the service will be subject to review as part of the bedded care review agreed as part of the medium-term financial plan in March, and proposals would be due to be brought forward next year. External residential care is projected to overspend by 993,000 at this stage. Resource allocation panels remain in place in relation to residential care and care and support at home to ensure appropriate scrutiny and control of hours being brought forward. For residential care places, we are currently being managed down to reduce spend in this area and in line with the outcome of the ongoing discharge to assess approach. Housing with care has a projected overspend at present of £239,000, including an assumed shortfall for this year on the agreed changes for Tiggotts Hall in that area. An underspend is currently projected on day services, which is contributing to reducing the overall overspend, along with a number of vacancies throughout services. Recurring development funds are projected to underspend by £425,000, which is also contributing to offsetting overspends in other areas. And the integrated NHS services have a projected underspend of 1.3 million. This relates mainly to vacancies throughout services, offset by overspends in complex care provision of 280,000 and within primary care prescribing of 1.3 million. A number of efficiencies are still progressing within the prescribing budget with a programme of improvements planned. These will continue to be incorporated into the position as the year progresses and any new savings emerge. Savings of 11.4 million were agreed for the financial year, and it's currently anticipated that 1.3 million will not be achieved this year, including care and support at home review reductions, commissioning reductions, housing with care, removal of long-term vacancies and charging for respite care. Delivery of transformation proposals remains a risk to the financial position. Continued resource and focus is required. It will be required and is being progressed to deliver and fully implement the programme. Risks to the position are set out in section 7. As previously mentioned, delivery of the efficiency programme is a risk. Demand for care and support at home, outstanding job evaluations, the volatility of prescribing costs and primary care improvement programme commitments are additional risks which remain under review as the year progresses. The expected use of contingency reserves will reduce our ability to maintain our agreed level in line with the reserves policy and to pump prime any future spend to save initiatives. In summary, the projected overspend of 6.5 million on integrated services is currently manageable within reserves and partner risk share contributions. However, the use of one-off funds to manage the continuing overspend position is not sustainable, and I've updated this morning around the work on the budget, the business case and medium-term financial plan. A significant amount of IGBs are in a similar position around reserves, with many holding no contingency reserves at this stage. Members are asked to note the current projected position for integrated budgets and set-aside services, note the non-recurring reserves position set out in Appendix 5, and authorise the Chief Officer to issue revised directions to Falkirk Council and NHS Forth Valley as per the directions provided at Appendix 6. And I'm happy to take any questions. Thank you, Chair.
Thanks, Marie. Again, an awful lot of factors in there, changing the position. It's the reserves position is worrying, but that's where we are. I'll bring in David and then Alison.
Thank you very much, Chair. I realise the importance of the underspend in community services in terms of matching your financial targets. Can I ask what the service impact is of that underspend?
So I suppose the main area of underspend in community services is vacancies. So throughout services, and it's spread fairly evenly throughout a number of services, we do have a vacancy management target in there as well. we added 1.6 million of a vacancy management target, which is being managed within that turnover of staff. We've had vacancy panel in place up to fairly recently, where heads of service came together weekly to examine any vacancies that were being brought forward for implementation or for filling. So we were taking that strategic view of understanding the requests, looking at outstanding reviews with that impact. So, but actually at the moment, that's mostly due to natural turnover of staff and perhaps recruitment and retention issues where we're unable to recruit. So around that, I don't know whether others might want to come in around the impact of that recruitment and retention, but certainly a lot of that's happening through natural turnover at the moment, and without too much trouble achieving that target at the moment. So I don't know whether Tom or others maybe want to come in around the impact in the services.
I see the business drive to keep that underspend. Yeah, I would do the same in that situation. But as a user representative, how are the people I represent being impacted as a consequence of that underspend?
Certainly the vacancy panel, that's something that we would discuss on a weekly basis around any vacancies that were coming forward, around safe staffing levels, vacancies would be approved, and we would manage, looking at outstanding reviews that are coming. So for example, vacancies coming forward around bedded care review, we would think, what are the implications of that? Should we be filling them on a temporary basis rather than a permanent basis? But certainly safe staffing levels are always adhered to, but I don't know whether Tom wants to come in around the specific implications. Thanks.
Okay, Tom.
They're trying to take as a risk management approach to this. One of the flaws, of course, in the vacancy management system is that it only looks at individual cases that come along, and that could of course have a much different impact on some services compared to others. So some might have quite small economies of scale and unluckily lose a couple of people during that period of time, and then you start to talk about whether those vacancies are to get filled or not. And what another service, and I'm going to the other end of the extreme, may have a huge service but hardly any turnover, in which case there is no impact on them. So there's a happenstance element to that. So what we're trying to do now as heads of service, take a very much a risk management approach. So each, Caroline, Martin, myself, etc., will look across our services and look at what the capacities are and where the potential impacts and consequences might be, and try and manage that across. It's obviously crucial, because that's implied very strongly in your question, in relation to the operational side of our activity. And I acknowledge the fact that whilst we have a big strategic agenda, maintaining as much capacity as possible in the operational side, it has to be the priority, because that's the public facing element of it, and it's where the public impact is. So we are trying to manage that, but we do always acknowledge the fact that any vacancy is potentially an impact, but where possible, as I say, we do try to manage that in terms of the risk of that specific impact.
Okay, thanks for that. I thought one of the reasons for asking was on television last night, where the hospital was on the news, that one of the, if not certainly one nurse, maybe an A&E consultant, whether she's Falkirk or not, I'm not terribly sure, made comment that they were working very hard because they were kept short-staffed, and that has a direct impact on the service users. So it's just in the public domain. So
okay, Gail, do you want to come in on that specific?
I suppose I wasn't going to come in on the specific, but just to say, in addition to what Tom said, the other thing we keep a close eye on is the performance, so our waiting list, etc., just to look and see where there is potentially adverse impacts on people as a result of staffing challenges, and the work we've done around our recruitment and retention has sought to minimise that, and particularly focusing on the areas which have the greatest impact on people. Obviously, at the moment, there are other challenges in terms of there's a lot of illnesses, and flu in particular, going around, which is impacting on staff absence, which again creates additional pressures around the availability of staff to deliver these essential services.
Thank you very much.
Okay, thank you. Alison?
Thanks. So 2 questions. One is about residential care allocation. The first one is about residential care allocation, and I'm conscious that that is where one of the biggest pressures are, and that you have processes in place to manage the balance of cost and patient outcomes there. But they haven't been successful so far, or fully successful so far. And I know that you have put in place some additional steps to be able to manage that. So my first question is about what confidence and controls do you have that this will be effective achieving the outcomes given your previous challenges? So that's question number 1. The second one is around the point made about contingency reserves and our ability to pump prime any potential spend to save programmes. What is the practical implication of this, and is there anything we can do to mitigate the impact of that?
Yeah, sorry. Thanks for your questions. Yeah, around the residential care placements. So we know that when we put measures in place around that it works. So we brought budget recovery plans last year to manage down the placements, and we managed to do that. So we reduced the placements by 50 during that period of reduction. So we moved back to a static position. You know, we kept the placements at a static position during the Shifting the Balance of Care project, so that it was clear to us if any additional long-term care placements were put in place, it was through that project and over and above that project. So because of that ongoing overspend, we're moving back to a risk-based approach to managing down the placements. So there's a resource allocation panel meets every week to look at the overall position, the number of vacancies in long-term care with long-term care providers, who's waiting for a placement, you know, where are the pressures. So there's a risk-based approach taken to that. So we know it was successful last year when we did that. So I'm hoping that will have the same effect again this financial year, to bring those placements down, and hopefully on a recurring basis, it brings that budget down to that manageable level within the current budget. Around the pump prime spend to save, yeah, our reducing reserves means that we don't, you know, we have less and less funds available for one-off contributions to spend to save initiatives. But for me, what I'm going to do is build that into the budget process and build that into the medium-term financial plan. So if we need one-off spend, I would need to build that in as an additional pressure. If we don't have available reserves, it'll just be built into that financial planning process. So obviously spend to save absolutely is one of the right things to do, as proposals are brought forward, if that brings us additional savings. So I would just build that into that medium-term financial plan. If we don't have one-off reserves available to use, I would build it in on a one-year basis and then remove it again. Hope that helps.
It does. And on the spend to save, I would think carefully about what you put in, and not all of that may be defined at the start of the year, given how the budget position tends to change as you go through the year. So I think there's probably a bit of thought about what that looks like and how you build that into the budget. But I'm sure you'll think about that through. Thank you.
Yeah, absolutely. That's one of the things we're going to be doing this afternoon, is considering spend to save proposals that are coming forward. And for me, you know, sometimes some of the implications around that are permanent staffing implications. So we need to be really careful about, you know, what is that commitment we're putting in against the potential savings that are coming out. So we will be considering that as we're moving forward as well. Thanks.
Kate, can I bring Stephen in next, and then Councillor Hannah?
Yes, thanks, Chair. Just to go back to the point of the concerns raised about vacancy management and impact on service delivery, I think even in a well-funded system, we always have vacancies, and that always impacts on service delivery. I think Tom, you know, made an attempt to make us understand about what the dynamic risk assessments looks like on a day-to-day basis, but I think it might be worthwhile, not today, but a future, either maybe seminar, just to look at that in a wee bit more detail, to try and give some sort of confidence to service users about what that looks like. I mean, we're already seeing an impact on the hospital site of a very early flu season, but I think to give an understanding that there is that capacity and that dynamic risk assessment, even in a pressurised system, that we can still, you know, we can still try to deliver the best service possible. Not for today, but probably a later debate. Thank you.
Okay, we'll take that suggestion away, Stephen. Thank you. Councillor Hannah.
Thank you, Convener. I wanted to ask, first of all, about the overspend in prescribing. This is a subject, as you know, close to my heart. I mean, there was additional funds put in to cover it, because this has been a stubborn problem for the whole time that I've been on the IJB, and I'm sure for considerably longer than that. I wonder if you could maybe say a bit more about what is being done to deal with that, because it is a continual issue, the overspend on prescribing, and clearly any overspend's uncomfortable for us all.
So I might just comment first and then maybe bring Tom in if he wanted to add any points. So there is a prescribing improvement initiative every year. Annually, our prescribing colleagues, we work really closely with them around any, they're looking at generic drugs, script switches, any improvement initiatives. They also look at, there's information comes out from Scottish Government around medicines of low clinical value. So where there isn't evidence that medicines are working, they look at any initiatives that can put in place to reduce the spend in that area as well. And there's been quite a number of really positive moves made in that area this year as well. But yeah, we're absolutely looking at that continually. I know we put additional funds in this year. What we're doing for next year is the same thing again. So we're addressing the overspend for next year initially, plus we're putting in 5.5% in planning assumptions at the moment. And when we've looked at the most recent trend analysis, that's a reasonable amount to have in. Plus we're also looking at additional improvement initiatives coming forward for future years as well. So we are continually working with prescribing colleagues around that. I don't know whether Tom wanted to add anything specific, but thanks.
Actually, rather than something specific, because that was a really comprehensive answer, and what I would have otherwise said, I suppose for the benefit of newer members, members of the Royal Well will be familiar with the kind of backdrop to this, which is there are some things we can control, and that's in relation to prescribing policies, the use of certain kind of drugs, things like that, and that's exactly what is being described there by Marie. But obviously there are things we can't control, and those are things like international markets and the costs of drugs, particularly new drugs. So when a new drug comes along, it is protected for a long period of time, and so therefore the cost is the cost imposed on by the manufacturer. It's only when they are able to come off license and move on to a more generic opportunity that costs can then come down. But even that has begun to level out over the last number of years as well. So the big differential that used to exist between the bespoke production drugs and the generics used to be large. It's now a lot smaller than it used to be. But I suppose it's important to understand that there are things in here that we cannot in any way control, but we are. And in fact, Forth Valley has a good reputation in terms of its prescribing policies and particularly within primary care.
Thank you very much for that fairly comprehensive answer. My other question is actually more of a plea. Over the course of this report and the previous report, we've heard various terminology. Things being described as a carer, home care, care and support at home, care at home, housing with care, and I struggle with this. Can we have a glossary? I get the difference between care in a residential care home and care in your own home. And it seems to me that it would be useful to have clear distinction between the different types of care, but possibly thinking about having one term that applies to it all, because my assumption is when someone has been identified as requiring a care service, they get the care service that they need. And all these different terms are not referring to a different type of care in your own home. Can I have some clarification on that, please?
Yeah, is that one perhaps we can take away and have a look at?
Yeah, I was just going to say we can certainly get some prepared.
Okay, thanks very much.
Thank you.
David, you wanted to come back in?
it's just taking up again from Tom's point. I understand the high level issue about drugs and prescribing, etc. And from my history and on a kind of personal basis, from knowledge I'm getting from some people since I joined the board, are we looking at polypharmacy? Because that's a major issue. It's being made known to me at the moment.
Tom, do you want to come in on that?
Yeah, the short answer to that, David, is absolutely yes. Of course, it was intrinsically baked into the PSIP that that's the kind of input we would want to see within primary care in terms of assessments of people's collective use of drugs and the most efficient drugs for the conditions that people have and how to manage them and in terms of what is required. So all of those reviewing is actually the bit that we're trying to impact through that programme. But in a much more general point, again, the not only the Medicines Optimisation Board, but again the various kind of other aspects of work streams that are going on are very much trying to focus in on that. We are genuinely, and I know it can sometimes not look like we're making progress when deficits continue to remain high. The best way I can describe it is imagine what it'd be like if we weren't doing these things. So in some respects, that at the moment we're trying to bend the curve the best way we can, but we are having an impact, and things like that are very much baked into the programme.
Okay, thanks for that, Tom. We've had a good go at that then. So if there's no one else coming in, can we then note the current position in relation to budgets and set aside services and reserves and authorise the Chief Officer to issue revised directions as per the report? Is that agreed? Okay, thank you. Can we move on then to item 8, which is... Sorry? Do you want to take a break now or after the next item? Now? Okay, let's come back at 10 to 11. Okay, folks, can we make a start again? Okay, thank you. So we're at item 8 then, which is Housing with Care, motion response. Caroline.
Thank you, Chair. This report is agenda item 8, Housing with Care motion response. As set out in the executive summary, the report addresses the motion presented at the IJB meeting on the 5th of September 2025 under Standing Order 22, providing detailed information on the re-provision of care at Ticketshaw Court, the options appraisal, expected savings and arrangements for residents and staff. I'll begin with the background and the core assessment before highlighting implications, supporting appendices and recommendations. Section 1.4 to 4.6 cover the background to the report, the Housing with Care motion. In March 2025, the IJB budget approved savings to address a 21 million gap over 25, 26, 27, 28. One of those savings was the re-provisioning of one Housing with Care facility. At the 5th of September meeting, the motion asked for the options appraisal that led to Ticketshaw Court being selected, alternatives considered and reasons for rejection, reasons for the Ticketshaw selection, why fewer than half of the tenancies have a resident requiring care, expected savings and how these are monitored, resident choice regarding care providers and quality of care, staffing arrangements, including suitable alternative posts, and the allocation process to ensure tenancies are prioritised for those needing care. The remainder of the report section assessment provides a detailed response. Starting with the options appraisal process within the assessment section starting at 4.7, the appraisal was conducted involving representation from trade unions, housing services, Falkirk Council HR representative and management representatives in April 2025 using a workshop model. 5 objectives were considered. The first was financial efficiencies aligned to the IJB budget. The second was care quality comparable with external providers. The third was the potential for the alternative models of care, such as assisted living and meal preparation. Complexity of care and business continuity. And the fifth is suitability of environments. That was the consideration of adapted bathrooms for complex needs and the layout of properties. Each Housing with Care complex, Glenfure, Glenbrae, Dorritor and Ticketshaw, plus the Do Nothing option was scored using a -1 to 3 scale. The descriptors of each are detailed at section 4.9 in the report. The scoring outcomes in section 4.10 show that Ticketshaw Court achieved the highest total score, 12, and was ranked 1. Glenfure and Glenbrae tied at 10, which was ranked 2, and Dorritor at 6, which was ranked 4, and Do Nothing was at 5. The reasons Ticketshaw was chosen are detailed from 4.11 to 4.16 in the report and are as follows. It fully delivered the required financial efficiency, which was objective 1. Care quality was expected to be mostly comparable under external provision, which was objective 2, noting that there's SDS choices to be considered as we progress. We'll say more about this later in the report. It aligned with maintaining complexes with potential for future service development, which was objective 3. It had lower overall complexity of needs and business continuity level, which was consideration in objective 4. And it maintained balance across the estate with regards to adapted environments. For information, Appendix 1 has the full redacted options appraisal process. Please note the redacted information is in relation to identifiable information, and it should be noted that this document was prepared as an internal document. I'll next explain the tenancy care split and why many current tenants do not receive a formal care at home service. In section Housing with Care Tenancies 4.17 to 4.22, the report clarifies 2 aspects of Housing with Care. The first is the tenancy side. Housing with Care properties are council tenancies managed by Falkirk Council Housing Services. open to people over 60 with additional needs who want to live near others with similar needs while retaining independence. Crucially, the tenancy is separate from care. Housing with care is not a registered care home, and care cannot be tied to the tenancy. The standard council tenancy agreements apply. The care side, the housing with care services are registered with the Care Inspectorate under Care at Home and Housing Support, which covers all 4 sites. Tenants with assessed eligible needs can choose how care is delivered under self-directed support, including external providers, Falkirk Council Care at Home, capacity permitting, or the use of personal assistants. Because care is a choice and not a condition of tenancy, and because tenancies may sometimes transfer, for example, bereavement to a family member already living there, it's expected that not all tenants will have an active care package at any given time. Current data shows sufficient capacity across all units to deliver more care hours than is currently being provided. I'll move on now to how we're prioritising housing with care allocations and then the financial information. In the sections actions being taken to support housing with care tenancies, 4.23 to 4.24, housing and partnership colleagues are collaborating to prioritise clients with eligible care needs for housing with care properties. To maintain occupancy and ensure efficient use of resources, vacant tenancies may, depending on demand, be offered to those with less complex needs. There is no requirement to have eligible care needs to move into a housing with care property. This ensures flexibility and timely allocations. Under section expected savings and financial monitoring, 4.25 to 4.26, the anticipated recurring saving is 150,000 following reprovisioning at Tiggettshaw Court. For 25-26, there will be a shortfall of approximately 80,000 due to HR process delays. Monitoring will be by the Strategic Planning and Transformation Board through the implementation progress, the Finance Oversight Group, which considers the budget implications, and regular reporting to the IGB on the overall savings programme. I'll now cover client choice and satisfaction. This was a key point in the motion. In section 4.27 to 4.30, assessment and care management, statutory reviews are being carried out under section 12A of the Social Work Scotland Act 1968 and the Self-Directed Support Scotland Act 2013. Clients retain the right to choose their provider, including external providers. Falkirk Council Care at Home, subject to capacity, or directly employing personal assistants. Post-transition, all clients will be reviewed at 6 weeks to ensure the care plan continues to meet assessed need. Clients have a named worker that they can contact with concerns at any time, and if requested, the review can be brought forward at any time. Moving on to staff support, under section 4.31 to 4.35, support to staff impacted, all housing with care staff were advised of the proposal in January 2025 across all 4 sites and encouraged to engage in the consultation process. The formal consultation ran in terms of staff directly impacted from the 18th of June to the 17th of July 2025. This involved one-to-ones with affected staff and union meetings. The HR process has been delayed due to a dispute lodged by Unison. In line with policy, no changes can progress until that process concludes. We have held vacancies in potentially suitable posts to maximise choice once the dispute process has been resolved, and staff support continues through team meetings and supervisions, but it is recognised that this has been extremely difficult and challenging for both staff and clients, and at times it's been identified that their welfare and well-being has been impacted. We continue to provide appropriate support as we go through this change. Implications are detailed from section 5.1 to 5.9. In terms of implications, the first is finance. The 150,000 efficiency spans 25-26, 26-27. Full recurring savings are still expected once implementation is complete, with potential for additional savings depending on the final staffing outcomes. Workforce reprovisioning impacts staff at Tiggettshaw Court. Redeployment options are being considered but cannot progress until the dispute has been concluded. We are currently at the process of progressing that. In terms of risk, the IGB's financial sustainability risk is rated very high. It is the highest strategic risk. There is also change process risk affecting staff and clients. Mitigations are in place, and these are overseen by the Performance Audit and Assurance Committee. Legal advice at times has been sought and has informed actions at the appropriate points as we progressed. In terms of engagement and consultation, the budget consultation was open to the public and had over 700 respondents, but who engaged either face-to-face or online. Appendix 2 details the full consultation process, and Appendix 3 is a frequently asked question document which is kept up to date on the partnership website and available to all. Lessons learned are being captured and will inform future work. In terms of equality impact, Appendix 4 outlines the considerations. So in terms of recommendations, the board is asked to note the response to the motion submitted on the 5th of September. There is no direction required at this time. I'm happy to take questions. Thank you, Chair.
Thanks, Caroline. That's a very comprehensive presentation. Can I open it up to members? Roger, take you first.
Thanks, Chair. I'm very disappointed that this report is full of many of the inaccuracies that have just not truths that have beleaguered this programme over the last number of months. And let's start right from the beginning. I would recommend people read a report by the Social Care Institute of Excellence, which is a government institute which looks at research into social care issues, and that is very clear that housing with care is not the building, it's the care, unlike what's been suggested over the last number of months, that there's confusion between the building being housing with care and the care being housing with care. It goes on to say that the research is quite clear that housing with care provides a very much improved service than other forms of care that allows people to remain in their tenancy, their house, for much longer with a more and allow them to stay out of residential care or hospital a lot longer. It's really positive about the positives of housing with care, unlike what's been suggested throughout this report and other reports, both in terms of the initial consultation, the proposals to this committee, and the EPIA, which it repeatedly says that the alternatives are equivalent to housing with care. The alternatives are not equivalent to housing with care, and research, which government research and good quality research, shows that the alternatives are not equivalent. So if one goes to consult on the basis that you can save a lot of money by giving the equivalent level of care, when that is not true, then that is not appropriate consultation. It's not worth the paper that it's written on. So likewise, if an EPIA comes out to say that the equivalent level of care is not going to affect protective characteristics, when evidence research would show that it does affect this protective characteristics, we need to review that and start again from scratch. So going on to the options appraisal, which the meeting that was suggested occurred, I attended as one of the union representatives. It was chaos. It was I was squashed flat right at the beginning of the meeting, so I did not feel I had a role to object or comment in any way. So my representation was pretty minimal. I had to jump in at points when it was completely clear that the scoring mechanism was making a mockery and need to be adjusted. And at the end of that options appraisal, a lot of people were saying, well, this doesn't make sense. We should have had other factors which should be taken into account, but we were not allowed to comment on that. These were the factors. These 5 factors have been described were the ones that were going to be used, and we couldn't adjust them in any way. So I didn't feel I was representing members in that at all. Moving on from that options appraisal was based on figures which many of the members, many of the residents and the staff wonder whether they were concocted to direct Tigges Hor to be the one that was chosen. They were manipulated. I don't know, but they don't seem to be. The figures that were led into this were certainly drawn up with some questions that staff and residents have about the objectivity of those figures that led to this scoring, and things like. Sorry, I'm going to need a bit of water. Simple facts which were discussed afterwards, but were not allowed to be drawn into consideration were: why are all the other housing with care facilities in the centre of Falkirk, and no consideration was allowed to be given to take that into account? Why was the figure of 150,000 come up with when one of the reprovision, I don't know why I'm using the term reprovisioning. It's not reprovisioning, it's closing down the housing with care service in Tigges Hor. One of the closing down options of Glenfure would not have saved sufficient, no, I think it's Glenbrae, sorry, would not have saved sufficient funds, so therefore it could not have been considered as meeting the options, meeting the figures that were needed. So that again was drawn out, but we were not allowed to discuss that in the meeting. But I think the key issue is that it's been said that the care is going to be equivalent after this closing down. It is not going to be equivalent, and it's not surprising that both residents and their families and staff have said, hold on a sec, we don't trust this people who are putting this in place when they're clearly coming out with things which are just not true, and quite insulting, because one of the things that was the comments that was made was that there's a lot of downtime by staff in Tigges Hor. Downtime meaning they're twiddling their thumbs. Staff, I can assure you, are not twiddling their thumbs with downtime. They're providing a service which is a housing with care service, not a care at home service. But Councillor Hannah's view of position about what's the definition of all these things, but there is a clear difference between care at home and housing with care, and I think we need to start with that difference, and the difference in the quality of care, which we know allows people to live in their house longer, their tenancy longer than the alternative that's been proposed. Thank you.
Okay, thanks, Roger. There's quite a number of points in there. Carolyn, do you want to come back?
Thank you, Chair. I'm not familiar with the report that Roger is referencing there. What I would say is across different areas, the housing with care models that exist are very different. It depends on the individual housing with care complex, so it's quite difficult to compare one housing with care unit with another one. And I do wonder, given it's a Sky report, if it's perhaps an English-based report, which again, there's different legislation, different context there. In terms of, the actual options appraisal process, specifically with regards to the financial part that was scored, if colleagues and members look at the actual options appraisal process in 3.6, you would see that actually Glenbrae, Glenfure and Tiggettshaw all scored the same for financial efficiency, not difference. In terms of the actual workshop that was held and the options appraisal process, prior to the options appraisal process taking place, there was a draft of the options appraisal document circulated to all people that were invited. We asked for comments about, are these the right things that we're evaluating? Is there anything that we need to add in? We also asked on the day if there was anything that people felt was pertinent that we had to consider. We did actually have a discussion about, we did talk about, we recognised that Tiggettshaw was in a certain geographical area and the other 3 units were in a different locality. And we actually discussed that. Should that be considered? And the consensus of the workshop was, and the group that they were there, Roger was one person that was there. There was another union representative there as well from a different union. And no one raised that actually that should be a factor that should be considered. We then, following the workshop, we circulated the paper, the options appraisal paper, to everyone that attended, and again asked for feedback. I've checked that paper went to everybody. It definitely did. We did not get any feedback around what should be changed, and that was prior to it going to SLT for recommendation. So we try to involve and collaborate as much as possible with those involved in the process around the options appraisal. So I'm quite disappointed that Roger's reflection differs so much from myself, and I'm keen to learn about how we can improve as we go forward, but it's certainly not my view of the situation.
Okay, thank you, Carolyn. Roger, I'll bring you in again.
Thanks. Certainly my recollection is clearly very different from that of Caroline's there. I would say that the other trade union representative from GMP seems to have a very negative view of Tiggettshaw and has expressed the view that she has always wanted it closed down. So I question their objectivity in this matter. I mean, it's difficult for me to say. I don't like to see my trade union colleagues, but I've been quite concerned about that. There was discussion, after the options appraisal, about whether the 5 criteria that it was based on were reasonable, and my recollection of that meeting was that we were going to have to stick to those 5, and no others were going to be considered.
Okay, thank you. Councillor Hannah, can I bring you in?
Thank you. I mean, this was my motion, and I thank officers for all the work that's gone into this report. I'm aware, as a councillor, I have spent more time on this particular IJB issue than just about anything else in my time as a councillor. And I know more about Tiggettshaw now than I know about my own home. Because I have dug into a lot of the details, and I really do thank officers for the work that they have done. I'm really, really concerned that Roger seems to regard this report as full of inaccuracies and not truths. My experience of health and social care officers is that they are very helpful, and I've never found them out in a lie, and I just feel I have to put that on the table because of what's been said. However, I'll go on to my questions now. I think the issue of housing with care versus care at home is an important one, because, and it's back to what I said earlier on, this question, what is the distinction? If I require personal care services and I am assessed as requiring personal care services, I would expect the health and social care service to deliver those personal care services. I don't care what you call it, frankly. I don't care if you call it a nanny service. I don't care if you call it any kind of, housing with care versus care at home doesn't matter to me. I want to know that I'm going to get the care service I need. And I wonder if you could clarify the distinction between housing with care and care at home, given that what we're talking here is about changing from a housing with care service to the provision of something that's called housing with care to something that's called care at home.
Yeah, Caroline, I'll bring you in on that one.
In terms of the service that is being delivered to people with assessed needs that are receiving a formal care package, it's care at home tasks that are being delivered. The housing with care is a care service that is registered with the Care Inspectorate. The care providers that we are looking to be the new providers for people that are living in Tiggetshaw have got the same registration, the same level of training, deliver the same quality of care. And, in terms of the majority of people that reside within Falkirk Council area, it is private providers that provide the care. I think it's over 1,600 people that receive a care and support service from private providers. They're very skilled at maintaining people to remain at home. And in terms of complexity of need, I think if you think about the housing with care model, that's been in place for over 40 years. Services have developed and grown, and we're now able to support people with more complex needs to remain in their own home, and they don't need to move into a different tenancy to receive the care that they require to continue to live as independently as possible.
Okay, thank you very much for that. You mentioned there in terms of complexity of needs. My understanding was that this was not the highest level of complexity that the need in terms of the residents, in that the highest level of complexity would result in someone going into a care home rather than housing with care. I wonder if you could clarify the level of complexity of the needs.
So there will be people that live in each of the housing with care complexes that have complex needs. When we look at the overall, so in reference to the options appraisal, we looked at the overall complexity of needs for the service that we were providing in each unit. In terms of that, Tiggetshaw was at the lowest level of need. In terms of when we talk about level of need, it might be helpful if I reference our eligibility criteria that was agreed at the IJB in March 2025. And really, it's the criteria that we use to decide if we're going to provide a service to someone, a formal service. And in terms of that point where we would provide a formal service, the level of need has to be critical or substantial. Critical is major risk to an individual's ability to live independently or maintain health requiring immediate or urgent social care services. Substantial level of need is significant risk to independence or health, needing immediate or urgent social care needs. What we are finding more and more is we're able to provide, bespoke services that can support someone with really complex needs, so that substantial or critical level of need to remain in their own home, which is where most people want to be. They want to remain as long as possible in their own home and don't want to have to move to somewhere else, whether it's a care home or a supported living environment or a housing with care unit, to be able to continue to live and receive that service that they require. And it goes hand in hand around the fact that the housing with care service, is quite an historical service, and we need to look at how we develop that going forward.
Okay, thank you. In terms, you mentioned the use of private providers. My understanding is that there's a range of different providers, which includes our own in-house service, private providers and third sector providers. I also understand, can you clarify if this is correct, that more than half of the care provided is provided by third sector and private sector? Do you have that figure to hand?
So, can I come in? Sorry. Is it in terms of all the care that's delivered? Yeah. So I understand it's around at 80%, 20%, so it's a lot higher. The majority of care that is delivered within the Falkirk area is delivered from either private or third sector providers. And actually, you know, I know we're going to be talking later on about another report, Shifting the Balance of Care. That's been our private providers that have provided that support during the day to individuals. And I would recognise that they're an extremely complex client group and cohort of individuals, and they've been able, on the whole, to be successfully supported to remain at home.
Thank you. Thank you very much. There was reference in the report to the care assessment and reviews. Can I clarify on the basis of what Roger has said, where all the housing with care properties, was the care assessed, was there a reassessment of the tenants in exactly the same way, or were there differences?
In terms of, so as part of the improvement programme that we had for all housing with care properties, we recognised that the assessment tool that was being used in all housing with care properties wasn't an appropriate standard and wasn't a recognised approach. We then, as a partnership, put an additional resource around that so that we could ensure that everyone had an appropriate outcome-focused assessment in place. And that wasn't to do with the re-provisioning process. That was to ensure that everyone actually had the appropriate assessment of need and to ensure that we were fulfilling our statutory obligation. That work went at different paces depending on the unit and the availability of resources. So we had to augment that by bringing in the social work teams to support that assessment activity. At different points, because there was perhaps protection issues, or there was perhaps new people moving into the housing with care units. We didn't want to repeat the practice that happened previously, where we weren't actually, appropriately assessing individuals to make sure they had the care needs, or did they require care at the point that they were moving into the housing with care property. So anyone that was new, perhaps moving in, we would redirect that resource to assess that individual. So that meant that it wasn't uniform, that we assessed everyone at Glenbrae perhaps over a 2-month period. We had to respond to what was happening within the service. So it might look like we completed assessments and then went back 2 months later. That isn't the case. It's to do with actually responding to the service needs. What I can say is at the point that we were completing the options appraisal, we had assessed everyone that was receiving, we'd assessed everyone that was perhaps receiving a housing with care service across all 4 units.
Okay, sorry, I've got so many questions. But, I just think it's important that we're absolutely clear about the situation. In terms of the eligibility criteria on which the assessment's made, my recollection is that we agreed as an IJB new eligibility criteria in March. Does that mean that all people who are receiving care services are being reassessed or have been reassessed since March?
No, it would depend actually on when they last had their assessment. So it would be like, a statutory review that we would do in a 6-monthly basis. So it depends like when that person had their assessment, and then what we're doing is we're applying the policy as we reassess or review an individual.
And what then is the kind of normal period between reviews?
It should be every 6 months that we review everybody. What we have done in Tiggettshaw following the options appraisal process and in preparation for the change that was being planned, we did go out and review everybody that was receiving a service from housing with care. Some people, the majority of people that were reviewed, continue to receive the same level of care that they were already getting. Some people experienced reductions in their care package, and some people actually had increases to their care package. It was very much dependent on the individual circumstances, and it was to do with we were recognising that we were moving to a new provider, and we wanted to make sure that we had everything in place and had addressed anyone's concerns around that proposed change.
Okay, thank you. There's reference in the report, and Roger has made reference to the excess capacity in terms of the staffing that are available in our housing with care services. And obviously, given our previous discussions about budgets, that how that comes about is a little concerning. I realise that there's got to be some contingency arrangements, but I wonder if you could say a bit more about the capacity within the units with versus the actual care needs.
So I think some of it's complicated by the fact that you've got the housing with care houses, the geographical houses, and then you've got the care service, and you don't require to have eligible care needs to move into a housing with care property. I think in the report I referenced exactly what the criteria is. You need to have additional needs, but it doesn't actually say you need to be able to you need to have care needs as such that require a service to be delivered. There is also something about the demand on the properties. So in Glenbrae, Glenfuir and Tiggettshaw, we tend to find that the waiting lists are a lot lower. When you compare it to Dorritor, Dorritor is a higher level. It's very sheltered. It's classed as in terms of accommodation because it actually is a coupon site, so meals are provided. There is demand for that service, and that's also recognised in the care capacity. So there's less. So across all 4 housing with care sites, there is capacity to provide more care than is currently required for the clients that receive a care package. But in Dorritor, that's less. There's less difference in the level of availability when you compare it to the actual care delivery. The other issue is the fact that individual clients have got the choice they may have eligible care needs that require a care service to be provided from the partnership, but they may choose not to have the housing with care service provide that service. We do have that situation across all 4 housing with care sites where people have said, we don't want the housing with care service providing the service. We want a different provider, or we want to choose option 1 and we want to employ a PA. And that is an individual's rights because it's not a care home. It is a tenancy situation arrangement, and we cannot tie the care to the tenancy.
Thank you for that. Sorry for keeping going. As a councillor, I get asked lots of questions by lots of people and given lots of information from a lot of different sources, and sometimes conflicting information. So you'll forgive me for being very picky about this. In terms of the allocation process, it has been said to me that there were situations where care staff were allocating tenancies. But my understanding as a councillor of our allocation process is that it has to be done by our housing staff. And in fact, I'm old, long enough in the tooth to remember some of the issues that there used to be about councillors allocating properties, but that's a very long time ago. So I'm well aware of the fact that it has to be done on an allocation process. I see we do have someone from housing on the call. I don't know whether you want who you want to answer that question. Can I have clarity about the allocation of the tenancy?
So the allocation is Falkirk Council Housing responsibilities, I understand it. Kenny Gillespie is on the call. Kenny, would you mind elaborating on that for us?
Yeah, thank you very much, Chair. And Councillor Hannah is very well versed, as she says there, about the allocations. And for clarity, the allocation of a secure Scottish tenancy sits with housing and only housing. We are the only department that can do that and manage the tenancy. And hopefully to help today to be very clear, the actual application, the tenancy agreement would only sit with the housing services, and that would be the point of contact of any issues regarding the tenancy agreement or anything within that legally binding document, Chair.
Okay, thanks, Kenny. Appreciate that.
So can I just check that in effect the tenancy in a housing with care property is the same type of tenancy as any other council tenancy?
Yeah.
He's nodding his head, so he's saying yes.
Yeah.
Okay.
Just to clarify, Chair, it is absolutely, it's a Scottish secure tenancy, which is all tenancies. That's the legislation that we are governed by for every tenancy agreement.
Thank you very much, Kenny, and thank you very much, Convener. I think I've hogged the microphone long enough, so I will allow one of my colleagues to come in.
Okay, thank you. Councillor Colley.
Yeah, I double press that. It's just habit of pressing the button. I suppose just a couple of comments before. I do have a couple of questions, but Chair, I do have a bit of a concern about stating that somebody, a statement that somebody had a predetermined opinion around tickets. So I don't think is helpful, and I also don't think is particularly fair, given that person is not here to be able to respond to that. And I don't want to get into a discussion about it, but really I just think in terms of fairness, if we're making comment about what somebody has or has not said, I think we need to give them the right of reply to that. So I just wanted to make a comment on that, and I did want to pick up that I think we need to be very clear, because there's been a huge amount of anxiety that Tickets Hall is closing, including actually closing, and that's the starting point that individuals had. And I think we just need to be very clear that Tickets Hall is not closing. Individuals have a tenancy, and their homes are their homes. And I think we just need to be very clear about that, because I really do worry about things that are said for the best of intent sometimes creating real anxiety, and we don't mean it to do. But I do have a couple of questions, and taking quite a few of mine, which is but I suppose a question on contingency planning, and obviously it kind of fits in a bit around SDS. If someone's package doesn't work out in terms of what they choose, or there is issues with the provider, what's the kind of contingency process for supporting somebody through that?
Thank you for the question. In terms of contingency plan, we actually have one named worker from the social work team who has been working with the clients that are receiving a service. There is some individual contingency plans in place, so perhaps individuals where there could be issues around capacity. We've built in individual plans with family members around how we would ensure if there's any issues at all with the care, how we would be notified around that. We plan to make contact with clients following the transfer to make sure that we can be proactive around any issues that are identified. And we would formally review each care package at the 6-week mark. But because we've got that one dedicated worker who's overseen by a team manager, everyone has the contact details for that worker and also has the contact details for the team manager. We've actually just written out to everyone so that making sure that everyone's got a full copy of their assessment and care plan. And we've asked people to come back to us if there's anything that you think's not accurate or if there's any areas that we need to consider further, please, don't hesitate to contact us. And we would go out and visit and have the conversations with individuals again, and make sure that we're making the adjustments in line with individual assessed needs. So we're very much, making sure that we're having that open engagement as we go through the process, but also recognising that we would formally review things at the 6-week mark, just so that we can make sure that the care package is appropriate and we're identifying any issues and being proactive.
Thank you. A second question, and you may have answered that and I didn't quite pick it up, so I apologise. In terms of providers on our framework, including our own in-house service, what kind of numbers are we talking about? Numbers of providers?
So I think for the care at home one, I'm looking at Marie because she probably knows the number better than me for the.
So we've got approximately 80 providers on our care and support at home framework at present, so there's quite a number.
Thank you. In terms of assessments and reviews, and I know this has been a process, and I know that you've been working closely with the individuals there. The chair and I were at a public meeting and we heard a lot of the concerns, and one was around outstanding reviews for that. What's the next step, and what are we going to choose within that? How many approximately are outstanding?
Okay, Chair. So in terms of reviews or updated assessments, at this point there's only 2 outstanding. That's because of individual circumstances. So we're working with the families, and we recognise that there's sensitivities around some family situations that are occurring, but we're confident that we'll be able to make sure that everything's in place as we progress through this process.
Thank you. And I don't know whether this is kind of going backwards or going forwards, or I'm not sure. I'm confused on myself. I suppose there's been some confusion around the scoring system for the options appraisal, and we sorry, someone keeps phoning me and it's coming through my watch. Yeah, no. Just in terms of the options appraisal, and maybe kind of give a bit of I can't even speak, explanation around the scoring system, because I think there's been where Tickets Off, for example, has scored 12. Why that's not it doesn't mean it's scored the best, and I think there's no doubt there's been really good support provided, but it's about the scoring system, and I think maybe it would be helpful just to explain a little bit more about it.
Yeah. So in terms of the scoring system, so the highest number would be the number that is recommended. So you weren't looking for, it wasn't the fact that it was the lowest number, because what we were doing was we were ranking it against the objectives, the 5 objectives that had been agreed that we would score each unit against. So 3 was fully delivered in terms of that specific objective. So if you take, for example, the financial savings, and then you think about, so based on the amount of, and really what you were looking at there was how much would it cost for us to provide that level of care if we externally provided it, commissioned it, and then that would then tell you if you would meet the objective, the financial objective of 150,000 on a recurring basis. So option 1, was to so in terms of option, looking at Dorritor, Glenbrae, looking at Glenfure, Glenbrae and Tiggettshaw, they would all deliver that objective. That was why they all scored a 3 in that area. And then if we go down to provide equivalent levels of levels and standards of care by a private provider. What we recognised was that, so the way that we're going to re-provision the care is through our care and support at home framework that has a 90% weighting towards care quality and 10 towards cost. So we were confident that the majority of providers that are on that framework provide the same level of care and same standard of care as our housing with care service. So that's why we graded that as 2. It scored 2 for every single complex. Why it didn't score a 3, why we didn't say it would fully deliver that objective, is because clients have got individual choice and may choose a provider or may choose a provider that is graded at a lower grade, a care inspectorate grade, than the housing with care service. But that is a person's individual right to do that. The other reason why it scored a 2 was because in terms of SCS options, people have got the right to choose perhaps an option 1 and may want to employ a PA. I can't say that that would be the same level of care as a housing with care service. So that's why they scored 2 across the board.
Oh, don't know. I can't see the red light. I need to sort of. Thank you. That's really helpful, because I think some obviously options appraisals are something that are not necessarily anything that are part of a strategic decision. They're operational documents. So I think sometimes it's helpful to explain a bit more. I suppose have I got a final question? Oh, I've got 2 final questions, and then you'll be glad I'm going to shut up. I suppose obviously it's been a really challenging time for the residents and their families, and for staff. So I suppose and it's extended over a significant period of time. And I suppose maybe the question, in your experience from what you're hearing back about, how are people finding that extended period and the extended period between the decision around tickets all being chosen and actually any implementation of that decision, just in terms of their feelings around that.
So in terms of both staff and clients, I think it's fair to say it's been extremely challenging. There has been individuals, both staff and clients, that have been keen to progress things, but have been worried about what impact that would have and how people would act from the people that live around them, and also in terms of some clients feeling under pressure. That they don't want to upset the housing with care staff. So that it has been very difficult, because there has been some clients and staff that have been keen to look at what's next and have the conversations, but we've been mindful that because of the HR processes that were ongoing, that all we could do is provide reassurance and advise people that at a stage that we would provide that information and ensure that we would engage with them around that process. But I think we've tried to be proactive and mitigate some of the concerns that people have had, because we haven't been able to give people concrete plans around the timings in particular. I think it has been very difficult, and we have been concerned once or twice. Certainly the social work team have raised concerns around perhaps the welfare of clients and perhaps undue pressure being applied. We've looked at that, and we continue to work with people around the issues and ensure that we're supporting people as we go through this change process, both staff and clients that are impacted.
Thank you. That's helpful. I would want to put on record that I absolutely think that individuals should be able to challenge this decision, including staff. But just to, I suppose it's not a without harm. I guess there's everybody in the middle of it is finding it difficult for different reasons. And final question. just around outcome monitoring. I suppose the next steps around perhaps reporting back, whether that's internally within the service to the senior leadership team or to the IJB about the once there's been the next steps about how people are doing in over an extended period.
So in terms of, I think within the report I referenced that this work has been overseen by the Transformation Board and within the Budget Monitoring Group. I think we also took a report to the Performance Audit and Assurance Committee, and I think I would anticipate that we would be asked to report further on as we go through this process around outcomes, because at the heart of this is about people, and it's about how do we ensure that we're supporting people in the right way with available resources that we have.
Okay, thank you. Roger, can I bring you back in?
Yeah, sorry, just one final point. I know I've gone on long enough, so I won't make. Just responding to one of Councillor Hannah's points in relation to jargon, social care jargon of needs assessment is probably jargonish from my view, because obviously if somebody falls over, they need somebody to attend to them immediately, whereas a needs assessment might well say, well, MEX would meet that need, even though there's half an hour for MEX to come in and see them. So I think the comment that their needs are met is probably something more about jargon rather than actual needs being met. So another example would be if somebody in a housing with care complex maybe is showing symptoms of urinary infection, the staff there will be able to pick it up really quickly and see they're not themselves, whereas staff who are popping in and out maybe 4 times a day for 15 minutes, who don't know that resident so well, won't pick it up. And then if you need to change the care, the housing with care staff can change the level of care very quickly, and that meets their needs. Whereas if it was the more traditional care at home system, then a reassessment would need to occur, and that could take quite some time, knowing the waiting lists for reassessments and how that might not be picked up so quickly, and that person might end up in hospital, etc. So whose needs are being met there, I guess I'm saying.
I would signpost us back to the fact that the majority of care that's provided to people that live in Falkirk Council is provided by private providers, and part of their training is around recognising changes around health. In terms of being able to change and amend the care package, we're actually able to do that on the same day if it's required. So I don't agree with your kind of characterisation around how care is provided and how we would be able to monitor that. Our goal is to ensure people are able to remain in their own home, whether that's if they're living in a tenancy in Ticketshaw or they're living in the community. And we make sure that we amend and adjust the care accordingly. I think even more for individuals that are receiving care within Ticketshaw, they have a named individual. We plan to keep that named individual attached to the people that are living in Ticketshaw for a period of time to make sure that we can that the care packages are appropriate, and we're able to, respond quickly to any changes that are required.
Okay, thanks, Caroline. Councillor Flynn, you've not spoken yet. I'll bring you in next. Sorry, we're not hearing you. You're not showing as being on mute, but we can't hear anything. It may be the headphones.
Councillor Flynn, I wonder if it might be possible for you to pull the mic down on your headphones.
Yeah, no, it's
We can
on.
hear you
Yeah.
now. We can hear you now.
Can you hear me now? Yes.
Yeah, we've got you
Oh,
now.
that's
On
good.
you go.
Thank you, Chair. Thank you. I was worried there. No, it was just really there was reference made to the MEC service. I wanted to, which won an award recently, I believe, just clarify something for my mind and everybody else's. First of all, it was mentioned that the average response might be 30 minutes. I don't know if that's true or not. I do believe the service is very good. I've experienced in the past with my mum many years ago. Is two things. One, do we know what the average response is? Because I do believe the MEC service contacts the person that raises the alarm through the Wi-Fi or speaker system. The other thing is, does the MEC service then contact someone from Falkirk Council and or the provider for that individual? Because it's important that we're not thinking that somebody falls over and they're left there stranded for a long time. I think that clarity is important in this, Chair. Thank you.
Thanks. Carolyn, can you come in on that one?
Thank you, Councillor Flynn. So I don't have to hand the standard around the response for MEC, so I can certainly get that to you. In terms of how MEC responds, it's actually got a prioritisation matrix. So depending on the individual circuit, so each person that receives a MEC service has got a care plan on the system. So it goes through to the contact centre, and then there's a worker that triages what's came in to direct about what level of response is required and how quickly that response is required. There may be individuals, so it's based on how a person wants their MEC service to be delivered. Right. So some people might actually choose that they want a family member to respond, they don't want the MEC service to respond. In these circumstances, what happens is the MEC service then contacts the family member, and then the family member would go and respond. In other circumstances, when it's the actual MEC's warden that's going to respond, they then apply the criteria around prioritisation, and then they would respond accordingly. They have to consider the other calls that are waiting, so they have to, look at what else is requiring a response, and then they make decisions around that based on risk.
Okay, no, thank you, Caroline, and I appreciate it's very, very varied, but I'm assuming people, that are getting the service currently anyway, may have the MEC service as well, so it's twofold. So I was just really concerned or slightly worried that we're not projecting to anybody listening into this that there was a concern about lack of response, and I don't think from what you've said there is. It was just important to clarify that. Thank you very much, and thank you, Chair.
Okay, thank you. I'm going to bring Councillor Hannah in again, and then Amanda, and then I think we will have to move on after that.
Thank you, Convener. I'll be very brief. I just wanted to say thank you to Roger for his clarification about the jargon, but also to kind of reassure him and others that, I worked in 3 different social work departments and 1 health and social care department for over 30 years. So it's a personal dislike I have for jargon rather than a lack of understanding. I also cared for 6-7 years for members of my family, so I have a familiarity from both sides in terms of the issues, but I'll put out that general plea. Let's be careful about explaining jargon.
No, it's a fair point for all of us, I think, to try and avoid jargon and acronyms when we can. Amanda, can I bring you in now?
Hi, it's thank you. It's just to ask a question about the MEC service, because we recently had them into the carer centre, and a lot of the stuff that they provide sounds very good, but they seem to have a very limited amount of staff. So when we're talking about shifting the balance of care and people coming out of hospital, then is there going to be 2 separate services for that, or is it just all going to be on MECs? Because the MEC staff for night time were about 3 people. So that was quite shocking, the numbers of staff they had on call. I didn't realise I thought it would be a bigger team of people, but it didn't seem to be. But they said they're kind of struggling with staff at the moment.
Thanks, Amanda. So in terms of the MEC service, see for shifting the balance of care, we actually put on additional staff.
Right.
So through the funding that was provided, we actually increased the numbers within MECs. In terms of what that MEC service is going to look like in the future, it's part of the kind of redesign work that we're doing. And we're really keen to look at how can we, so one of the successes we've had with MECs is perhaps people that previously would have had to go into a care home, we've actually been able to maintain at home by having like check visits. That's probably what they were talking about, or you know, day visits where we're actually you know, supporting someone around their toileting needs. And I think we're keen to look at how we can develop that. In terms of the staffing levels, what would provide reassurance that in terms of safe staffing, we have to monitor on a weekly basis what level of demand is on the service and what level of staff do we require on duty at different, because MECs is a 24/7 service, and we adjust the staffing levels dependent on that. So while it might seem to the staff that there isn't a lot of people on, that's perhaps because there isn't the demand around the times that it's required. And you know, we keep that under review because it's a legal requirement.
Yeah, I think the concern was that it was such limited overnight staff that, well, most things happen overnight with falls and things like that. So that was a bit of a concern that the staff was quite low compared to what it was like during the day. I don't know if you can answer that.
So I think perhaps it was the night shift staff that were there.
Right.
So they might feel that they're busier, but actually in terms of the call outs, there's just as many during the day. So I would go back to that bit about every week we look at the demand on the service, and we're able to look back in data over 2 years, because we recognise there's seasonal adjustments around certain things. So you recognise that, you know, sometimes there's more demand on the service at different times of the year, and we recognise that in the staffing levels. So all I can do is provide the assurance that we do keep that under review on a weekly basis, and we change the staffing levels depending on the demand that's required on the service.
Thanks.
Okay, thanks, Caroline. So we've had a good go at that. A lot of questions, a lot of information there. The recommendation is that we note the report. Are we content to do that? Okay, thank you. Can we move on then to item 9, which is the Strategic Risk Register? Marie.
Thank you, Chair. This is the Strategic Risk Register, which is brought to IGB twice annually. So since last reporting, no new risks have been added to the main register. There are currently 9 live risks recorded in the register. 1 is considered very high risk, which is financial sustainability. 7 are high risk and 1 is medium risk. The IGB Strategic Risk Register continues to be maintained and reviewed on a regular basis, while the ongoing reviews, which have been intimated in the appendices, are carried out and implemented. Appendix 5 now shows Children and Families Corporate Risk Register information for completeness and for oversight pending the finalisation of the integration scheme. I'll just make a note of some of the changes that have been made since last reporting to IGB, starting at 4.10. So under financial sustainability, this has been updated around the current budget strategy, which has been reported to the IGB, and moving towards agreeing an updated business plan and medium-term financial plan. At 4.11 around partnerships, this has been updated to reflect ongoing engagement and communications with partners, and also the development of the IGB market facilitation plan in line with the strategic plan development. Around commissioning at 4.12, this is now updated to reflect ongoing work to develop a comprehensive contract register, and to note that the Care at Home User Intelligence Group has now been convened in relation to Care and Support at Home framework renewal. Whole system transformation has been updated in relation to the Shifting the Balance of Care project. Resilience and business continuity. A workshop has been held with the extended senior management team to assess the readiness of the HSCP for a major incident. The HSCP communication strategy around major incidents is also being developed following feedback from that session. An action plan from these sessions will be brought forward early in the new year. And finally, just to mention again, around children and families, they have now been transferred from an operational perspective into the IJB, pending agreement of the integration scheme, and a summary of that corporate risk register is attached to Appendix 5. I'm happy to take any questions. Thank you.
Thanks, Marie. So no overall changes to risk scoring, but there are quite a few changes in the detail below that. Alison?
Thank you. And mine is probably more an observation and a request rather than a question. And it's really about the environment that we operate in. There is obviously a lot of risk there. And I'd like to see us moving towards a more proactive, strategically focused risk management framework that looks at the actions we can take now to mitigate not just the immediate risks we've got, but also the risks in the medium term. And when I'm looking at some of the controls we have, they seem to be about the here and now rather than that medium term. So it's really just a request as we're looking at some of these, particularly in relation to, say, the workforce, financial sustainability, we look at those and say what controls do we need in the future, particularly as we start to transform the system, we shift the balance of care, that will change our risk profile. So what are the controls that we need? So rather than wait until those risks start to realise themselves, let's think about what are the controls we need now to make sure that we manage those as we go forward.
New system. Thanks for that, Alison. Yeah, absolutely. We have recognised that we need to update the strategic risk register. We held a workshop probably around this time last year, actually, looking at do we have the right strategic risks recorded. Should we have new ones? How should we update them? So there's a number of reviews outstanding, and we've had a bit of capacity issue around taking those forward. So we've now got Ewan Murray with us as our business and governance lead, and he's looking at taking forward changes to strategic risk register, actually in line with some of the comments you were making there. So I'm sure we'll be looking forward to bringing forward some of those changes in due course. Thanks.
Okay, thank you. David and then Councillor Hannah.
Well, thank you very much, Chair. I was really just to agree totally with the comments that Alison's just made. I think there's a real opportunity to do something about it. It's seriously quite upsetting to see all the work that you're doing and having a standstill, position across the risk register. Yeah, I find that must be quite annoying to you. It's certainly disturbing to my mind and why we're in a standstill situation. What are the principal hurdles that you're experiencing that causes us not to change the risk register as it's currently formatted?
So you're absolutely right. It's not that there's nothing going on. There is a lot of activity ongoing. But I think at the moment, one of the hurdles we've had is around that capacity to take forward those reviews that we recognise we need to do. We're going to do some deep dives around some of those strategic risks. I might bring you in a second just about some of the actions that you might be taking moving forward. So, obviously financial sustainability is recorded as very high. I think that's absolutely appropriate. I think that we are doing a lot of work to bring forward plans for the medium term. But for me, the overall funding position nationally, not just locally, the national funding position, the national challenges, the demand information that we're seeing coming forward, I think absolutely it has to remain at very high. And whilst, yes, we would love that to come down and we would like that target to be lower, absolutely. The target should be lower and we would aim to get there. I think it's absolutely appropriate and reasonable that it remains at very high, whilst we have those ongoing challenges and whilst our partners have real ongoing financial challenges as well. Around some of the other risks, there has been a bit of a standstill pending those reviews that are ongoing. For me, and I'm probably stealing a bit of Ewan's thunder here, but around the makeup of the strategic risk register, how it reads, how it looks, the complexity of it. So I might actually bring Ewan in because I know he's got some thoughts on how we might take that forward and plans for that. Thanks.
Thank you.
Okay, over to you, Ewan.
Thank you, and thanks for the comments and questions. I guess the capacity that I bring in does give an opportunity to take a fresh eye in terms of the strategic risk register, and there is some for me just around the basic structure of it and digestibility, and does it
give members a really easily digestible view of the strategic risks, the controls in place, and what is the art of the possible in terms of mitigating some of those risks. So I kind of got a plan of action between now and March to go through that work as a priority. The other thing we do need to keep our mind on is, from an IGB perspective, the strategic risk register is the risk of not delivering against our strategic plan, and there's a dynamic bit around obviously going into a period of process that Tom and his team will lead again around reviewing the strategic plan, and we'll need to update and keep an eye on risk in terms of how we reflect risk in terms of a revised strategic plan. So it's going to be a dynamic process over a period of time, but there's also some pieces of work that have been outstanding for a while that just need a bit of focused time and energy around to get done and get to where they need to be. Thanks, I hope that's helpful.
Thanks, Ewan. Yeah, that was helpful. Councillor Hannah.
Okay, thank you. Just a very brief question. I wonder if you could say a little more. I mean, in the register, we've got risk heading 3 partnerships and 7 whole systems transformation, which are currently assessed as being high, but the target is low. So we've got quite a long way to go in both of those. So I think it'd be useful if you could say a little more about what's going on there and what kind of time scale can we begin to see a change.
So again, obviously, there is a lot. It's not that there's no work going on around these areas, and I think we mentioned at the last IGB as well about, are those targets reasonable? So although we're saying it's high and it's a low target, part of the work that you'll be taking forward is to review, is that target reasonable, and where might we aim to get to around these partnerships? There's been a lot of work around, working along with our third sector, and we've had comms and engagement strategies around that as well. So we've done a lot of work with them, especially during the partnership funds process last year. So we engaged with the third and independent sector around that process that we took forward, and obviously part of that was around reducing the funds that we were actually allocating, making sure we were bringing them in that journey with us, making sure that they understood the financial position. So there's been a lot of communications ongoing. So we are moving forward with the next year's partnership funds process at the moment to make sure that it's going to live within its means. Again, we're communicating with third and independent sector around that process as well. So, but what I would say is, those targets at the moment, we are going to be reviewing those targets to see if they're reasonable and appropriate moving forward, and we'll bring that back to the IGB as well. Around commissioning, so there's a lot of work ongoing at the moment around a full and comprehensive contract register. We aim to start bringing a paper to IGB next year around all of the activity around commissioning. So now that we've brought the team together, we would quite like to be bringing a paper around what commissioning activities are ongoing, what direct awards have been put in place, what contracts are moving forward, what renewals are moving forward, all of the information behind that, and any issues with providers that are being raised. That would need to be a private paper that would be brought to IGB fairly regularly, but I'm really keen that we bring that report so that IGB members are aware of all of the activity that's going on around commissioning and around our providers. So I would, again, that'll be updated as we move that forward as well, and along with the work that Ewan's going to be doing. I hope that helps.
Thank you.
Okay, thanks, Marie. I think the comment was made earlier in a different context that we're doing an awful lot of work to stand still and just think what it would look like if we didn't do that work. It is concerning that there are lots of high risks, but I think unfortunately that is just a realistic assessment of the position that we are in right now, and it's going to take us a while to get out of it. So we have considered and commented on the report. Are we happy to otherwise note the terms of the Strategic Risk Register report? Okay, thank you. Can move on to item 10 then, which is the locality planning update. Caroline, I think you're going to kick us off on this one.
Thank you, Chair. I'm actually going to bring in Gordon McKenzie, who's online. He's the locality lead and oversees this work, and he's going to talk us through the report.
Thank Caroline. Thanks, Chair. I'll make some brief comments on the report and then hand back to you, Chair, for questions, if that's okay. We've got James Patterson with us online as well, who's led the work behind the report. He'll help me answer any questions that you've got. The report provides an update on the current progress of Central and East locality plans. As you'll be aware, the Central plan came to the IGIB back in January. It's now in the implementation phase. The East plan came in June. It's in the implementation phase now, and the West locality plan is before you today. We've adopted the same approach in terms of the priorities, the guiding principles. We've tailored that obviously to the circumstances of the West locality through a 6-week consultation and engagement with local groups and individuals. And that has, through a working group, created the delivery plan in front of you today. It's appended as to the main report, and that's my overview comments. I'm happy to hand back to you for questions.
Okay, thanks, Gordon. Can I open it up? Okay, Alison and then Councillor Colley.
Thank you. And I'm deeply conscious that I'm new to the IGB and that the locality plan builds on the pattern of previous locality plans. And when I read this, it didn't give me the sense of ambition that I think as an organisation we have for our communities. And when I was reflecting on that, I think the reason it didn't give me that sense of ambition was that it felt quite process focused rather than outcome focused. And I would really like to see more in there about the outcomes that we want to achieve for our communities. And I would like to see more of that quantified so that we can actually say, yes, we are doing that. But also, if we're not doing it, we can then take the steps to make sure that we take the remedial action. I think this bit that sits alongside that is also just about the controls that sit alongside this. So yes, we say within the plan, currently we have a long wait for homelessness. Great, we want to address that. How long is the current wait? What is our target to get to? But what is quite often important is not just the averages, it's the outer extremes of the system. So how many of our community are waiting? What is the longest 10% of that? So for me, I would like to see some control metrics in there as well. So it's really, I think, I would love to see this just tightened up with those outcomes, the key performance indicators and the measures that tie around that, and the control measures as well, so that we can show the difference that we're making to our communities, but also if we have challenges, we know that we have challenges and we can intervene timelessly, not timelessly.
Gordon, do you want to come back on that?
Yeah, thank you. Really helpful comments there. Thank you very much indeed. There are delivery groups for each of the locality plans. We'll take those comments back and we'll update that our delivery plans accordingly, put in more metrics as you suggest, and it is a work in progress. These are the first. This is the first iteration, as it were, of the locality plan. So, yeah, really appreciate the comments. Thank you for that, and we'll take that away and incorporate into the work of the delivery groups. Thank you.
Thank you.
Okay, thank you. Gail, do you want to come in on this as well?
Yeah, just to add to what Gordon said, so this is the very first iteration, so it's on a journey. I think the feedback's really helpful. I think it's really key to think, over 2026 we'll be developing our new strategic plan, so we want to see a linkage both feeding in and feeding out from the strategic plan. So I think it'll be a bit of an iterative process, but we start somewhere and we keep on getting better, and that's the approach that we take. So I think the feedback and the input is really helpful for us as we think about how do we structure that new strategic plan as well.
Okay. Thank you.
Okay, thank you. Councillor Colley.
Of course, I'm delighted to see the last locality plan, which is the area that I live in and represent, but I'm not taking it personally. And I think the points about, you know, measuring the difference that we make, and I think that's really, I mean, because that's the point of it, about making the difference. But also around that iterative process and tying it in with a strategic plan. I think the only comment I did want to make, and I don't want it to sound like a criticism, because I know that it is actually very challenging. We've got lots of appendices around services in our area that the NHS, and a bit of a link to what is in our third and community services, and living in that area. I know the huge amount of services and support that are available, particularly in the third and community sector. And I suppose it's about, just as we move forward, not necessarily we need to have a big list of everybody, but how we make sure that individuals in our communities know about them, because some won't be in Alice, some will not be in that other directory, but actually how do we make those connections? And I know that we are making some of those with community link workers, but just that wider, how can we build through, for example, through libraries, through other community settings, to make sure that individuals know what is there, because there is a huge amount and some fantastic services in the area.
Thank you, Gordon.
Yeah, no, I again agree in helpful comments, and you look into the detail of it, and we've got similar issues in how to get to different groups of people within, not necessarily individual groups, but people within those groups, looking at the carers side of things. A lot of carers saying they don't know about certain services, what's available. So we've got to get a lot better in getting the message out there that those services are available. We've got to make sure we're connecting with the right people in order to make sure the information is available in a lot of different places, so that people, as they go about their communities, are able to access the right information, or can get it online if that's their choice.
Okay, thank you. So the recommendation then is that we approve the West Locality Plan and Delivery Plan. Get that right? Are we happy to do that? Sorry, David, I didn't. Do you want to come in before we close?
I really just wanted to expand on some of the things that have been already said, which I fully agree with. I think there's a good opportunity in the marketing facilitation plan we're about to create, to actually brand what we do, because I don't think a lot of the population really know who and what we are. You know, the population generally knows what hospitals, or at least thinks it knows what a hospital is, and it kind of knows what a council does. But there's a brand identity. I think there's an opportunity to grow here, and that would address some of the problems have been already mentioned. So I just want to say there's an opportunity to do a lot here in terms of branding in the market facilitation plan. Thank you.
Okay, thanks, David. Yeah, it's a fair comment, I think. Can we then approve the West Locality Plan and Delivery Plan? Great, so we now have all three delivery plans approved, which is great. Thank you to everyone who's been involved in all of that great work. Okay, item 11 then, we are nearing the end. Communications and engagement update. Paul, welcome.
Thank you very much. So very pleased to be presenting this day, hopefully quite a straightforward report. So as you know, this quarterly update provides an ongoing monitoring of the implementation of the partnership's communication and engagement strategies and the associated joint action plan. So the content of this update covers the period July to September 2025. During this period, the partnership received at least 12 pieces of media coverage, totaling a reach or opportunities to see value of over 500,000. Coverage was received in the Falkirk Herald, Falkirk Live, Daily Record and STV News, and in this period mostly focused on the deep dive and improvements presented at recent boards and committees within the Adult Weight Management Service and Dementia Services, the early positive impacts of the Shifting the Balance of Care project, and the work underway within Housing with Care. So the partnership held one consultation during this period, which was the development of the West Locality Plan, which you just heard about, and additionally engaged with over 100 people while attending 11 community groups. In terms of other engagement, the partnership hosted a pilot training workshop for staff to raise awareness of our carer representative programme and to help staff learn more about how we can support our carer reps and link in with opportunities across the partnership for those reps to take part. So a full list of the media coverage received, events held and consultations open during this period is provided at the end of the report. And then lastly, I'd want to note the ongoing and upcoming messaging which is being coordinated nationally regarding winter pressures. This includes reminders to staff and public of the winter vaccination programme, and all staff are encouraged to take up the flu vaccine, with details of drop-in vaccination centres and ways that you can get your flu vaccines being shared regularly. So that's it for today's report. So I'll just return us very quickly to the recommendations, which are to consider and comment. Thank you.
Okay, thanks, Paul. Are there any considerations or comments? Alison.
I'm a bit like a broken record, I'm afraid, and I'm back at measurement again. And again, I would love to see some targets and some measurement here. So what does actually good look like in our communications? What do we want our social reach to be? And again, when we look at, say, our press, how much of that is positive, how much of that is negative, and what would good look like in that, so that we can actually, when we look at these reports, we can actually play it in context and we can actually see what is the difference quarter and quarter and quarter, because you want to see us going from strength to strength to strength, and actually quantifying it in that way allows us to see what that is. But it's also, I think, as we move forward, our communications and our engagement activity is going to become more and more important, because we've talked a lot about strategically how we are going to need to change the behaviour as a shift in our health and care system. So what does that demand of our communication system? What is that strategic plan, and how are we going to measure that and see that it is working effectively? So I think while we're at this stage, let's get the basic framework in place. Let's then think about what that strategic plan is, so that we can then monitor it, because this is going to be critical as we go forward, even more of a plank in our armoury than it is today.
Do you want to come back on that, Paul?
Yeah, no, I think very, very good points indeed. I think on a high level, I can probably say that the sort of metrics that we gather, you can see that we are growing quarter on quarter in terms of our social activity, and we sort of seem to keep that momentum going. I think a sentiment score for our media coverage might be a useful addition to this report, so very happy to go and work on that and add that in. I think you might guess from the coverage in this period, the sentiment score might lean more negatively, but I think usually it is focused on that positive. So I can definitely go and look at adding that in.
And I think my point is also tying it back to our strategy. So if you look at our demographics, who are our target market, what are the right channels, what does that look like, what is the engagement in those channels, what is our reach in those channels, and therefore what is that doing to support our overarching strategy, which as a communications professional, I know you will know, and it's just so that we start to make that link back between our overarching view of what we're trying to do strategically to this element of it, because this isn't just going to be a corporate type communication piece as we go forward. It's got to be a core strategy. It's got to be a core plank of our strategy. So that's why I'm pushing this a little bit more than perhaps I would have.
Oh, perfect.
Thanks.
Very happy to hear that. Thank you.
Thanks, Alison. Councillor Hannah.
Thank you, convener. Just want to say thank you for the report, Paul. It's really useful. And another kind of comment about my length of time on the IJB. In the time I've been on the IJB, I've seen a huge improvement in terms of both the communications and the consultations. So congratulations to all the people who have put in a lot of work on it. However, when we look at the consultations, I think we really need to look a bit more deeply at who it is we're reaching and how we're reaching them. One of the problems with consultation is that the more articulate, the more vociferous and the angrier people are more likely to engage in consultation, and it's really important that we reach those people who don't have computers or who don't want to use their computers, who don't necessarily get out and about a lot. one of our biggest target audiences is the vulnerable people for whom we are providing services, and it's really important that we work really hard at getting them involved in the consultation. And I can see Marie wants to say something about that, and I'm aware of a great deal of work that Marie has been doing on that front.
Yeah, can I bring you in, Marie?
Thanks, Chair. I suppose it was just to say, obviously, members will be aware of that lessons learned approach we're taking around certainly the budget consultation. And I think that's learning that we can take across any consultations that we're doing. And we're absolutely really keen on making sure that we increase our reach and reach the right people around any consultations that are going out. And also some of the feedback we got was around understanding what's in those consultations and making sure that we are doing some due diligence around that before they're coming out as well. And I know there's been quite a few lessons learned around targets approach and the overall budget approach as well. So we're absolutely taking on board those lessons, and hopefully going forward that we're learning from those and taking those forward. Thanks.
Good to hear. Learning never stops. Thank you. Thank you, Convener.
Okay, thanks very much for the report, Paul. I think we've considered and commented and hopefully come up with some good additions to the report for future, but thank you for all the work you do. Can we move on then to item 12, shifting the balance of care evaluation? Again, Caroline, I think you're going to introduce this one.
Thank you, Chair. It's actually Claire Chapman, who's joined us online, is going to provide a presentation based on the report.
Okay, over to you, Claire.
Thank you. Good morning, everyone. I'm Claire Chapman, Home First Lead. So I'm just going to take you through the report this morning, and I do have a PowerPoint that's about to be shared up. Just while that is sharing there, just for everyone to note the data and the progress made around shifting the balance of care. Note the largely positive impact for patients and carers. Note the evaluation report that was attached to the original paper within your pack, and note that there is a future business case that is in development at the moment with options appraisal for recurring funding to support future models and sustainability. So just for everyone's information. So thank you, Cheryl. If you could go to the next slide. Thank you. So I suppose in terms of shifting the balance, what I'll go through is just really, well, what was the initial issue? So the initial issue was really stubbornly high delayed discharges and long lengths of stay for our Falkirk patients in hospital. As we've discussed today, the whole system financial challenges experienced by the partnership in NHS Forth Valley are increasing demand and change in demographic within our patient group, and really the capacity within the acute hospital, which was becoming increasingly challenging. So that was sort of setting the scene around what. And so what are we doing? What is shifting the balance of care? Well, this is a discharge to assess approach. And the reasons that we've done this was to really look at an additional 32 patients to be discharged back home into the community to receive the right care, the right time and the right place. So the project and discharge to assess aims to release capacity within the acute hospital, and that creates more flexible space, demand and capacity for our planned care. This also supports the development of our community pathways to provide health and social care closer to home, reducing the hospital pressure, motivating our workforce and leaders, and improving system efficiency generally across health and social care. This also gives us an opportunity to utilise health and social care costs to support good outcomes for our patients. Thanks, Cheryl. So what approach did we use? So we had a relatively short lead-in time to start in this project. So the additional 32 discharges were in June. So what we developed really quickly was a multidisciplinary team with key stakeholders that are listed within the pack there in the report. We are trying to support a whole system cultural change, which we're looking to evidence and reflect on a weekly basis via our PDSA approach. Working really closely with Paul and our partners in NHS Forth Valley around our communication plans around the project, why we're doing what we're doing and what this means for patients and carers. You'll see further on in the report, we're informed by our data around patient outcomes and what this means for people. And importantly, this is underpinned by our discharge to assess principles and home first principles, which are supported by the Discharge Without Delay National Collaborative that NHS Forth Valley and Falkirk Partnership are signed up to. Okay, so I suppose what's the data telling us in terms of our discharge to assess model? Well, within the month of June 2025, we actually achieved 32 additional discharges on top of our usual discharge profile. So what that meant was an additional 8 people went home with a package of care, 9 patients were able to be supported into long-term care accommodation, and 16 patients were supported specifically through our discharge to assess model. So what this means is really around rehabilitation, reablement and assessment at home in a timely manner. So we supported patients that really were anticipated to be on the trajectory for long-term care within the hospital site, and we supported them home with up to 24-hour care at home for a period of time. So our day support that's been mentioned within the IGB today was supported by our external care agencies, and our nighttime support was provided by our mixed service, along with utilising some equipment and smart technology. Our goal is to provide an up to 48-hour wraparound 24-hour care support model to then look to reduce that care and support as the assessment and rehabilitation progresses for the patient at home. So just to mention a few of the assessment team, our social workers were involved from our Home First service and localities, our allied health professionals, so occupational therapy and physiotherapy were involved, along with our district nursing and continence care, but that is not the full list. We had quite a significant multidisciplinary team, which included our third sector colleagues as well. We anticipate and we aim for an up to 21-day assessment period, and within June we were around about that time, but we had to acknowledge that these patients that we did support home had been on hospital for quite a long period of time, so their length of stay was long, which leads to deconditioning and additional risks. Thanks, Cheryl. So in terms of the activity of the project so far in this approach, so I've got July to September 2025. So we had 48 patients within this period discharged supported by discharge to assess. And quite powerful data around that was 60% of our patients did manage to remain and are remaining at home with a package of care. 8 people, which was 17%, did go to a care home. However, the key is that their assessment did take place at home, and that was a really informed decision following a robust assessment period. We did have 10% of patients going back into either a community hospital or an acute hospital site, but I think that does reflect the frailty and the health of the age group that we were supporting. Sadly, it did pass away. However, it was important to note that throughout the assessment period, we did take into account people's end-of-life wishes and tried to fulfil them as much as possible. And we had 2 other patients that declined a service or were supported to a respite resource. So you'll just see there the benefits. This was around home-based assessment. So what we're trying to do is support people to have that more homely assessment to get a true reflection of their support care and needs over a good period of time, and not go straight from that acute environment into a care home. Our care home reduced post-assessment, so we're able to measure kind of what that package of care looks like for those 60% of patients, and it did really support an effective discharge model in terms of patients' readmissions and primary care, and our colleagues across those services were really key in supporting that. Thanks, Cheryl. So really important, because I've mentioned cultural change. So, what's been some of the themes that we've experienced? So at the moment, we feel as a group and using our PDSA sessions that trust in this process is increasing. We're maintaining the weekly sessions to support questions and answers with our staff. And now we've got staff actually looking to refer patients to the service. We did initially look at patients that were purely and are delayed within our hospital site, but I think it's really positive that actually there's an appetite to ask these types of questions. And we're using specific patient case examples to support staff in that learning and understanding. So there's some really powerful comments there that I'll just go through. So a staff member across the acute site said, "I initially wasn't sure, but then I heard how well our patient is doing and I was amazed. I can't believe the difference her being in her own home has made to what she can do. I really thought she would need long-term care home placement, but I've heard she is managing with a package of care, which is great." So it's just really around supporting the sharing and learning around that. Thanks, Cheryl. So in terms of our client, patient and carer feedback, we are in the process of ongoing engagement, and we're supported through our home care managers as part of the project in relation to obtaining responses from our client group. One of the patient feedbacks was it's been very helpful. I've got my confidence back after a few bad falls. The physio support has been very, very good, very supportive. I can't say how wonderful. And I'm so glad to be home. I'm looked after and feel better being in my own house. And I think those statements are really key in terms of what we're trying to achieve around that wraparound care support and assessment at home. Thanks, Cheryl. So what I have now is just for everyone, this is a video from one of our patients who came home, and he was happy for this to be shared within this forum. So it's just a couple of minutes, so I'll just play this for everyone. So thank you, Cheryl.
My name is James Robertson, and I left the hospital after 7 weeks. They were going to send me to a rehab, but because I couldn't walk properly, they sent me home, and they decided to give me carers instead and physio, which has been very good. When I got the carers, I didn't know what to expect. The very first time they came to the house, they were here from 6 in the morning till 9 p.m. at night. Eventually, that was stepped down, and today I get the care in the morning to get washed and dressed, and I get a lunchtime to give me medication, and then the evening time to put me to bed. Yeah, I was introduced to MEX, and I got an alarm put around my wrist. If I fall, I just press the alarm, and it's immediate call, there's immediate answer. And within 10-15 minutes, I've got somebody at my door to lift us up again and put me back into a sitting position. It's very, very good, and something I'm glad I've got round my wrist. Definitely. The physio comes in, and I do exercises standing at my Zimmer, and then I walk up the hall, down again. I can go outside, we walk round the block and back in. It's beneficial, it's very beneficial, but I've just got to keep this going because with the support I'm getting from the physio, that I should be able to get back to normality of walking in the near future. Yeah, it's I would say you recover better being at home than what you do being at the hospital. Because at the hospital it's long dragged out. Well, at the home, if you get your physios, you get your exercise, and your carers give you your meals, so you know that you're being well looked after, and this is a good thing for recovery.
Thank you. Next slide, Cheryl. Thanks very much. Thank you. So just to really emphasise, I suppose, patient journeys, there's a few examples here that we've put on a timeline, and you'll see just someone's experience within the hospital site and their duration in hospital. So patient A here, this patient was supported within the June period of time, and they'd had a length of stay of over 50 days. You'll see there in relation to the reasons: severe lower back pain, spine compression, chest infection, COPD, and various other medical conditions there. So quite a lengthy length of stay in hospital. We identified this patient as becoming delayed on our hospital site and felt that actually they would be really appropriate for shifting the balance of care and a discharge to assess model. We were supported through MEX, REACH and our carer centre to support, and there was ongoing rehab, as you'll see there, the assessment period at home, undergoing exercises, rehab at home, mobility and good engagement. So that package of care was stabilised to 4 calls a day with 2 carers, and really positive outcomes for that patient in relation to repositioning, self-aided and self-management in relation to the activities of daily living. And that care is ongoing, which is an excellent outcome for that patient. And then there's another example. This patient had a longer period of time in hospital, which was 147 days. So as we all know, in relation to risk, deconditioning, hospital-acquired infections, etc., a really long, lengthy period in hospital due to a road traffic accident. You'll see there in relation to several injuries and bone and shoulder damage. So this patient, 147 days, was supported through the discharge to assess model, which was indeed 21 days. There was minor adaptations made to the property as per the assessment as that progressed, and overnight calls were reduced as the assessment showed that person became more and more independent. That package of care then stabilised at 4 calls a day, and that is ongoing as well. And so just an excellent outcome for that patient. So in terms of outcomes, just to mention, these outcomes are very individual to particular patients. So we've had patients that just wish to progress to, mobilise into particular areas in their home. We had a really powerful situation where there was a couple and one of the wife just wanted to be able to sit at her dinner table with her husband, and she actually achieved that outcome. So really powerful part of the assessment process in terms of individualised needs and support. Thanks, Cheryl. So just in relation to the data, so this is a graph showing our Falkirk delays over 2024 into 2025, and you'll see there that we did have a significant peak over the summer period. So just to draw your attention to June 2025 there, you'll see sort of a significant lowering of the delays, and that is the impact of shifting the balance of care there. And we look to maintain and sustain that level of delays for people on the acute site via this model there. So it's just showing the impact of the project. Thanks, Cheryl. This is a whole system tool that is completed by 3 partnerships, so Falkirk, Clackmannanshire and Stirling, and also NHS Forth Valley. This is around whole system escalations and pressures across the system. You'll see, and apologies, the dates are very small, but the start of the chart is around May 2025. 2 key projects there. We had the frailty unit, which has opened around about May 2025, and then shifting the balance of care, which was the start of June. So you'll see a significant step down just in relation to the whole system escalations there. So what some of those mean, it means non-standard care areas being used and then stepping down. So, 4-bedded bays having an additional patient, treatment rooms in use, for example. So really that's a powerful indicator that the site is managing better and that actually people are within the right place receiving the clinical care from their speciality. So a real positive impact on that Opal score and how that site is reflected in terms of the pressures. So it reduced significantly. Thanks, Cheryl. So in terms of the model and how we develop this moving forward, I've mentioned confidence in the model, which is around that management of culture, risk thresholds, how we can share an understanding of them, and a lot of that work is built into this. We've gone through with daily and sometimes weekly and daily reflections on refining the model. We've got really clear links and building links with our primary care colleagues, district nursing, our Constance Care staff support, technology and equipment, which have been proved really, really helpful in terms of overnight support, a system called the Canary system and just checking, which shows people's activity over periods of the day, have really informed the assessment process. We've reviewed and are reviewing, the roles of our carer support workers, what that means for them, the reablement approach and how we reduce and support people to reduce that care at home. I've mentioned risk thresholds there, but importantly, this model links into our in-house care at home redesign and what's possible there, along with our integrated discharge service and the developing frailty unit, for example, on site. So there's multiple transformational projects that this really is closely related to. And I know that I've been on this meeting listening, carer involvement has been mentioned, and what we are planning to do and what we aim to do is consult through the integrated discharge service development around starting that planning process as soon as someone comes into hospital, is admitted to hospital, and having those good conversations all the way through that patient journey. That's the end of my presentation, but I'm very happy to take any questions or comments, and thank you very much.
Thanks, Claire. It's good to see those data, but it's also good to see the personal stories in there as well, and the impacts on people's. Again, that's what this is all about. I think many of us had very high hopes for this pilot, so it's good to see that things are going so well, and look forward to taking that forward. The comments or questions from members. Councillor Hannah.
Oh, thank you, convener. I don't have a huge amount of questions on this one because I was privileged to already have this report at the Integration Joint Board Performance Audit and Assurance Committee. And I managed to get most of my questions in there, but I really do want to make the comment that this project really excites me. It's what the Integration Joint Board should have been about all along. It's about getting people back into their own homes and enabling people to stay there, which is what the vast majority of people want. So I just feel I've got to say well done to everyone who's been involved in this, and I look forward to seeing it extended. One question I did raise before and I just want to raise again is, I know that we've had the transfer of the monies to enable us to provide the additional care services, but going forward there's also additional demand on our primary care services, and I think it's important that we look at how as it rolls out, as I confidently expect it to do, how we give the support that's necessary to primary care as well.
Yep, Gail, do you want to come in on that specific point?
Thank you. Yeah, so we're, as Claire mentioned, we're currently in the process of developing a business case, so that's considering all of the different implications. I think one of the key things about this project is it's operated in an agile approach. So on day one, we put something in place, we continually improve that. So we learn from what we were doing and we continue to improve that. So that included adding our GPs into a multidisciplinary team. So understanding what the impact is on our primary care services as well. So that will feed into the business case. We've been speaking to GP colleagues actually just yesterday about that, around what that looks like. So we'll include that, and you'll see that reflected when you see the business case coming forward.
Yeah, thanks, Gail. With a bit of a Christmas light show going on there, I think, for a minute. So there are a few colleagues want to come in. So bring in Amanda, then David, then Alison.
Hi there, it's just to ask, and I know you're saying you're going to involve carers and a lot of stuff, but out of the patients that you discharged, were you taking into account like the numbers of unpaid carers that were within the discharges? And with the savings that are being made, is that then more investment to be put into unpaid carers? Because they're the ones who their health suffers as well through the discharging of their loved ones. So thanks.
No, thank you. I'm certainly able to answer the first part of the question in relation to unpaid carers. So we have a worker dedicated to the initial discussions around what discharge to assess and what this particular project may mean to the person. So they have those discussions with everyone that's involved, really with the patient at the time, that will be involved in their care and support. And there have been occasions where, where we felt someone has been appropriate, but actually, on further discussion in relation to our eligibility criteria, if there's a high level of carer stress and support, then we have looked at options there. And actually, this approach is also about a more homely environment. So if home wasn't appropriate at that very point in time, it's what are the options that are available in supporting those people within those conversations. I might hand over to Caroline and or Marie just around the additional, any savings that were made or any additional plans moving forward. But certainly I'm taking all the comments that are made today just in relation to unpaid carers. So I appreciate that. Thank you.
Okay, I'll bring you in on the finances, Marie.
Thank you. Mandy, I'm assuming you're talking about potential savings that are going to be coming forward around, whatever those options might be. So I came along to the Carer Centre, not yesterday, the day before yesterday, just to chat through with them any implications of budget decisions that are going to come forward. As I've mentioned, we've got an extended senior management team session this afternoon to go through any proposals, and what will happen is we need to do a full equalities impact assessment on any proposals that are coming forward where anybody with a protected characteristic has to be considered in that, and we would understand the implications there. But we're really keen to keep carers involved in those decisions and consult with yourselves. Obviously, I'm keen as well around those lessons learned that we share that information with you before the consultation goes out to make sure carers understand it. I'm going to come along to the Carers Voices group as well to chat through any proposals that are coming through that consultation as well. So we will make sure that you're involved in that, and I'm keen to continue that as well. Thanks.
Okay, thank you. David?
Yeah, thanks, Chair. It's a really interesting project. It's interesting to see how it's growing, and I imagine it'll grow even further. But what went through my mind here is what is emphasised is where you position the workforce. So if you have the rehabilitation supportive staff in the community, I understand that. Is there not an opportunity to turn it on its head here to have more rehabilitation staff in the community to reduce the number of referrals to the hospital?
I can come in on that as well. Or sorry, Gail, do you want to come in?
Yeah, I was just waiting for my light to change. So I think that's a really good question. And if we look at sort of new national policy around shifting the balance of care, and that means not just putting additional requirements and demands into the community, but actually moving resource to go along with that. So logically, that would follow that in terms of that additional resource, the more we can support people to receive the care they need and have appropriate pathways in the community, so care closer to home, the better. Logically, that would reduce the number of people attending ED, would reduce the length of stay that people have in hospital, and I think that's one of the key things that we've demonstrated through this project has been the reduced length of stay. And obviously when people stay in hospital longer than required, that obviously impacts on their condition and potentially their longer term ongoing care needs as well. So that's absolutely what we're aiming for, and this is about starting somewhere, learning from what works, and then using it to evidence future opportunities to move and shift resources closer to home so people can receive the care in the most appropriate place, recognising that obviously at times the acute hospital obviously is the most appropriate place. We want to make sure that when that is the case, there is capacity and the right care resource available in the acute hospital as well.
I might add, just to add, that I have some clinical experience in moving rehabilitative staff into the community and cope with some of the ongoing problems due to the success of that strategy, because there was less work for orthopaedic surgeons, for example, in the hospital. That's a different issue, but that modelling works really well, because people wait weeks and weeks to see an orthopod or a physician or whatever. And if rehabilitation staff can prevent that referral in the first instance, it's a very effective use of the workforce. Thank you.
Yep, absolutely. Alison?
Build on a couple of the points here, and this does excite me as well. I've got one question, which is 40% didn't manage to stay at home. How worried should we be about that? So that's question one. And the second piece is really about where do we go with this and the business case. And when we do that, I'd like to see a full economic assessment rather than just a budgetary assessment, because I think that will tell us some interesting things as well. And I think that's important rather than just looking at the budgets. The second piece really builds on your point about how scalable is the solution. And quite often, I think certainly when I've looked at papers before, the scalability is constrained by budget availability rather than anything else. I would rather we looked at how scalable it is without that as a constraint, and then work backwards from that. So what could we do if we could make the budgets work? Would be my starting point, and then let's have a conversation about the budgets.
Okay, thanks, Alison. Gail, do you want to come in on that?
Just to agree with the various points that you make. So I think there's been the opportunity to do shift in the balance of care has taken a leap of faith across whole system leaders to move money from NHS budgets to social care budgets. I'm pleased to say that there seems to be a little bit more of that. So in terms of there was a recent announcement a few weeks ago around slippage money being shifted from NHS into social care. So again, we've put in a proposal around that. We're just waiting to hear back, but that would allow us to increase the amount of support that we're providing. So I think it feels to me we're starting to see that shift happening, but I think you're absolutely right in terms of at the moment, it very much depends on looking down the way at budgets and getting that whole system leadership to be pointing in the same direction, as opposed to it happening more naturally. So it can be quite difficult. And I think what we're seeing in Falkirk and Forth Valley is quite a small scale in terms of its potential. But in terms of thinking about that economic impact on society, that potential has to be massive. I think it'll be really difficult to work out, is my view. But I think that is absolutely the lens that we should also be looking at this through.
There are models and there are health economists whose job it is to do this sort of thing. I've worked with them in other places. So it does rely on an awful lot of assumptions again, but the cases can be proven. I think we're at the beginning of this work, and it is the right direction of travel. Everyone knows. I mean, if you get a situation where you're achieving what the patients want, which is going home, and doing it cheaper at the same time, you've kind of got to like that, haven't you? Councillor Colley.
Yes, thank you. I think just in terms of economic considerations about the economic impact on unpaid carers of measures that better support people at home, and I think sometimes that's kind of a bit forgotten. And that's as everyone, or most people will know, is something that I've been involved in for many years. So for transparency, I would like to say that. I think the project's fantastic, and I think looking at some of those outcomes for individuals, and particularly seeing that someone's story about being able to go home and being able to start moving around, and I think anybody who has experience of someone being in hospital, the care's fantastic and the attention and all that sort of thing, but the reality is that people spend a lot of time in bed or in a chair and don't really get moving around a lot, and inadvertently, we don't mean to, but we do harm to people. And I think it's brilliant. And as someone who has been involved from the very beginning in relation to legislation around integration, it's fantastic to see some of the intentions about that real shift in how we invest and how we invest in people. And it's always a challenge when we have significant demand at acute level about how you actually get that transfer of money and resource into activity in the community. I suppose I just had one question was around about the linkages with services like hospital at home, hospice at home services, and I suppose linking in then into some of the work around the palliative care strategy and the services and support that are part of that as well. And I suppose that question around the business case and the next steps about making sure all those connections are made. And I don't want to sound like teaching Granny to suck eggs, but just some assurance that those will be.
Yeah, so it's obviously a piece of work that is incremental. It's not perfect by any means. That's probably most of everything we do isn't perfect, but we hope to move in the right direction. So in terms of those linkages, I think there's still opportunities to increase the joined upness of the various services that exist out in the community. So I think that's again really helpful. We will make sure we reference that in the business case. I see this very much as an iterative process in terms of, so when we first did the tiny small Chester change this time last year, there's a huge amount we learned from it, and then I think every day from when we started this, we've continued to learn and develop the model of care that we have in place, and that will continue to develop to make sure we are more streamlined and there's less potential disruptions through handoffs between different services.
Okay, thank you so much for the report, Claire. So we're being asked to note the report. I'm going to say we look forward to the business case rather than simply noting it. And can I also add an initial recommendation that we thank everyone involved for all the work on this project to date, because I think there is a general sense around the room that it's such a good project and there's such an excitement around it. So thank you so much. Are those recommendations agreed? Thank you. Okay, we've finally reached the last item, item 13, which is the assurance report from the Performance Audit and Assurance Committee. Gail.
Thank you. So I'll just introduce the report and what it brings. So the Performance Audit and Assurance Committee met on the 21st of November and considered a number of reports as set out in this report, which is in front of you today. They did decide that they did feel assured by the information that was provided, and there was a number of items that they wished to be highlighted to the IJB. At this stage, I should apologise, there is a sheet missing off your papers, and I'll just read out what was written on that, and I know that that's been circulated by email this morning to you as well, so apologies for that. So the committee wished to highlight to the IJB the fact that they noted the approved the audited annual accounts, so they considered them and improved them, and they also noted that while it was a positive audit report, it did highlight the significant financial pressures which continue to be challenging. In relation to the National Audit Report and Inspections Overview, the PAC Committee sought assurances on the timescales for delivering the promise in Falkirk, and recognising the significant positive progress with delivering the promise so far, with lots of positive feedback being received from those with care experience. It noted the recent inspections and praised the staff who've been working on these services for their hard work, which has enabled these positive inspections. So that included the HMPIS inspection of HMP Glenacle that I referenced earlier in my Chief Officer report. Also, Grahamson House Care Home was recently inspected, and that showed overwhelmingly positive feedback. And Lockview Hospital was also recently inspected, and the PAC Committee sought assurances around the actions being undertaken in relation to addressing the matters raised within the inspection. So on the final page that was missing, what it would have said is that the PAC considered the initial evaluation of the Shifting the Balance of Care project, noting the impacts to people supported home to receive assessment for ongoing needs at their home with appropriate wraparound support to support reablement. It noted that 60% of people supported through this project have remained at home with an appropriate package of care, and improvements have been seen across a number of indicators, including delayed discharges. The committee recognised that people generally want to return to their own homes at the earliest opportunity, and appreciate the project has been key to enabling this. And finally, the PAC Committee considered an in-depth review of the Housing with Care service, including an overview of the service, concerns raised, processes invoked, and improvements that have been put in place over the last 18 months, as well as lessons learned through the implementation of the budget decision to re-provision care in one unit. The committee raised their concerns over some of the practices that had emerged over time, but were assured that managers within the Health and Social Care Partnership are taking a proactive approach to deal with the issues identified. So hopefully it's helpful. I'm just going to Councillor Hannah chairs that PAC Committee, and as the chair, I just wondered if there's anything else you wanted to add.
I don't think so. I think we've my concern was that we had a suitable comment on the in private report, and I think it's taking things forward. When we have private reports, we need to look at those parts that we can say publicly and make sure that is there, because there is always the concern that people have when there's private reports that there's something to be hidden, and that's not the case. There are good reasons for reports being in private, but it's important that there's comment on those parts that are publicly available.
Indeed, I mean there are good reasons for some things having to be private. Although my preference is always to have everything in public if at all possible. But as the committee is doing kind of detailed work on behalf of the IJB, then we kind of need to be assured that appropriate scrutiny has been given, which can be difficult to assess when you can't know the detail. But so it is useful to have that kind of high level summary of the issues that have been discussed. And I guess the two substantial issues from committee have both been well discussed today anyway. So we have that assurance, I would think. Does anyone want to come in or comment or ask questions? Okay, can we note then the assurance report produced by the Performance Audit Assurance Committee? Okay, thank you so much. Thank you. As it is the last meeting of the year and we are into December, I think I can now say Merry Christmas to everyone. I hope you all have a great festive period and we'll see you back again refreshed and ready to go in January. Thank you so much, everyone.